Good morning, everybody. I think we'll get started, so we're on time. For those of you I didn't meet last night, I'm Dr. Jim Crutcher. I work here at Swedish, and like you, I'm a graduate of the UW orthopedic program and proud to be that. I had an opportunity to come work at Swedish here 2 years ago, and I'm still here. So anyway, I want to welcome all of you to this day 2 of the 56th annual LeCocq Lecture. As some of you heard last night, this lecture is named in honor of John LeCocq, who is a visionary and luminary in the orthopedic community here in Seattle. Many of you might be wondering why this place is called Swedish Hospital. It was founded about 120 years ago by a small group of physicians who were Swedish immigrants, and there's a big Scandinavian immigrant population in this area, so they were some leaders in the medical field. And Dr. LeCocq, who I don't think is Swedish, but he was one of the early practitioners here, was one of the early chiefs of staff at Swedish Medical Center, and you can read in the program about all of his other accomplishments. So this lectureship was named in his honor because of his accomplishments and his endured to this day. And it's great to have everyone back. It's been 4 years since we had a pandemic-induced hiatus of this tradition. Before we go any further, I want to thank Dr. Chansky, Planette Sanchez, and her team for putting together this whole 2-day program, including the program here today. So thank you, Planette, for doing all this. It's my honor to introduce our guest speaker. For those of you who didn't attend last night, Dr. Charles Nelson is a native of Philadelphia. He went to medical school and residency at the University of Pennsylvania, did an adult reconstruction fellowship at HSS in New York, and then returned to his hometown to practice orthopedics at the University of Pennsylvania, where he's currently the chief of adult reconstruction. He's very active academically, received a lot of scholarly and academic awards at the University of Pennsylvania, is an active member of the AAOS, the AAHKS, the Knee Society, the Hip Society, and I've learned the American Board of Orthopedic Surgery. And he comes here today to continue his lectures and share his wisdom on adult reconstruction. I've known Charles a little bit through the academy, and he always makes very knowledgeable presentations on our topic of adult reconstruction. So without further ado, please help me welcome Dr. Charles Nelson.
Thank you so much for having me. What we'll talk about is, and hopefully it'll be applicable to even people who don't do joint replacement, but we'll talk about management and classification of bone loss during revision knee replacement. These are my disclosures. I don't think any are really relevant. I would say that I do have a patent that has not been, that's not licensed by anybody, that may play a role in some of this, but management of bone loss is important for optimal outcome during revision knee replacement. And we, in my opinion, need a reliable and quantitative classification system to develop treatment algorithms and compare different treatment alternatives. And when we start talking about revision knee replacement, it's really about building a construct on a foundation. So in the city of Chicago is a great skyscraper city because it's built on limestone, and limestone is solid and can support the weight of large skyscrapers. So when we're doing a revision procedure, we really need to first establish a solid foundation, and then we can use stems to get appropriate alignment, and then we can use, we'll call them fillers, to facilitate alignment and fixation, and that would be, and stability both axially and rotationally. And different fillers, they may include things like cement, metal augments, bone grafts, porous metal cones or sleeves or megaprostheses, depending on whether the bone loss is contained or not contained. Now, the most notable classification system for managing bone loss is the Anderson Orthopedic Institute classification. But I think in some ways it's a little bit vague. So, on the femoral side, the F1, essentially there's a normal joint line and normal condylar offset, and there may be small cavitary defects. You don't need any augments. The F2s have segmental bone loss, either one or both condyles, and augments are required, but it really doesn't quantitate the degree of bone loss. And then the type 3s are severe bone loss, but again, not quantitated, where you might need an APC hinge or megaprosthesis. It's pretty much the same thing on the tibial side. So I think we need a classification that is reliable. It's quantitative. It looks at key anatomic landmarks. It looks at joint line restoration and stability. And we talk about
Hey, good morning, everybody. Morning, everybody. If we could start moving our way back to our seats.
Okay.
All right. Well, as everyone's moving back towards their seats, first off, I just want to thank Dr. Nelson for coming out, giving us a wonderful series of talks over these past 2 days. We really appreciate you taking your time. And I'll just briefly go ahead and introduce myself to anyone who I may not have had the pleasure to meet yet. My name's Kurtis Carlock. I'm one of the fourth-year residents at the University of Washington, going into arthroplasty, and I've had the pleasure of helping to put this event together over the last 2 days. So thanks to everyone who's helped along that way. I'll kind of be helping to moderate the next 2 resident-led sessions this morning, where we're going to step through some cases, first in revision total hip arthroplasty and then revision total knee arthroplasty. We'll have a series of, or some faculty members will come up to the front and serve as a panel. We don't have a microphone for the panel today, so we will have to kind of speak up a little bit loudly, so hopefully everyone can hear. But our first panel is going to be on revision total hip arthroplasty. Our panel members will be Dr. Nelson, Dr. Manner, and Dr. Hernandez. So if we could have you guys come on up to the front of the room. And our first talk will be on, yeah, you guys are fine right now. And our first talk will be by Dr. Madeleine Jackson on instability in the setting of revision total hips.
Great, thanks, Curtis. Good morning. Thank you so much for the opportunity to speak this morning on my favorite topic in pediatric orthopedics, revision total hip arthroplasty and stability. I know that Dr. Nelson's lecture yesterday was on optimizing outcomes in revision total hip. Unfortunately, I wasn't here yesterday morning as I'm on nights at Harborview and was in the operating room doing fasciotomies at 7 a.m. So I imagine that some of what I'm going to say was covered in much greater detail and with far more expertise yesterday morning by Dr. Nelson. So please bear with me through amateur hour here. And to the panel, please feel free to interrupt me at any time. So instability is a very challenging issue in total hip arthroplasty, and the number of re-revisions for polywear and other implant-related issues has declined. I think hip instability has come to represent one of the most common reasons for revision and re-revision in total hip. It's something that everyone doing joint replacements deals with, and I'm going to try to hit some of the highlights here this morning. So a quick outline. So we'll start with the case. This is a 44-year-old female who presented to one of our emergency departments in February of 2022 with an anterior prosthetic hip dislocation. She'd undergone a primary total hip in 2017 at an outside hospital in Minnesota for arthritis in the setting of hip dysplasia. She'd gone on to early instability of her prosthesis. She'd had multiple revisions over a several-year period. Her last revision was a few years back. She was dislocating with increasing regularity since then. And of note, there was never any evidence of infection during any of her previous procedures or workups. This is what I think is her complete history relating to the hip, just based on the outside records that we had in the system. Her primary was done in 2017. She dislocated early, requiring a couple of closed reductions before undergoing a first revision in July of that same year with a headliner exchange. The op note made note of titanium debris at the time of revision and obvious posterior superior impingement. Supposedly, she then underwent another revision at an outside hospital in Virginia, but we don't have records of that. But she returned to Minnesota, underwent another revision in April 2018 with a constrained liner cemented into her well-fixed cup. Quickly failed this as well. Similar revision was performed in August of that same year with another constraint liner cemented in and what was noted in the op report to be more appropriate anaversion and abduction. But falling through the floor, sorry. At no point were her stem or cup revised. So in terms of some other pertinent history for her, the patient experienced housing instability. She was an active smoker, had a psychiatric history, and used chronic opioids. After her initial presentation to our ED in February of 2022, she underwent post-reduction in the operating room, and then unfortunately redislocated within a week and was admitted to the hospital for revision. So here she is in the OR during that initial closed reduction. You can see how horizontal her cup is. You can see she's impinging there in abduction. And then these are images from the following week when she represented dislocated again. And here she is reduced. So any comments from the panel at first glance? What's wrong with this hip?
Well, so one thing is there's a notch in the neck, so you can see the person's impinging. That's probably why there's all that titanium debris. That stem might fracture at some point at that level, in that area. So as she abducts, she's going to hit the neck against the area of the stem. So it's probably coming from that dual mobility insert that is cemented into that device. The cup, I agree, is horizontal. Horizontal cups usually isn't a reason for instability, but it can be a reason for tension, particularly with abduction. And then what we don't know from this imaging is what's the anniversary. So somebody reported 20 degrees anniversary. That doesn't mean it's 20 degrees anniversary, right? So I want to cross table lateral. If I had any concerns, I'd want a CT scan so I can accurately assess version. I also want to look at the version of the femoral component compared to the knee angle. And as I mentioned yesterday, some recurrent dislocations are because people don't revise both parts. Here they provide either part. So with all those dislocations, at some point the person probably should have had something with a better position.
So just briefly on instability after revision, rate of dislocation in primary total hip is about 2%. The rate jumps quite a bit in the setting of revision. Studies vary, but overall rate of instability is considerably higher, between 6 and 20%-ish. Some studies suggest that instability has become the most common cause of aseptic re-revision, partly as a result of improving technologies, reducing the rates of revisions for other reasons. This was a Kaiser study published in JBJS in 2015, looking at all aseptic revisions over a 10-year period. They found a 10% re-revision rate overall in their 629 revision total hips, with 50% of the initial revisions for instability and 43% of the re-revisions for instability, and a 5-year implant survival overall after revision of about 87%. Similarly, this is from the Journal of Arthroplasty in 2019. They retrospectively reviewed about 2,600 aseptic revisions over a 10-year period with a mean of 6-year follow-up. There were 211 re-revisions during the study period, and the overall survivorship was very similar to the previous study at 88%. But again, the most common reason for re-revision was instability at about 52%. This is a 2013 paper from CORE assessing risk factors for dislocation after revision. And essentially what they found was that a history of instability was a predictor of future instability. So they looked at about 1,150 total hips over a 6-year period. And the rate of dislocation in the follow-up period was about 10%, similar to the prior study. The median time to dislocation from revision was about 77 days. And at the 90-day follow-up point, the risk factors of the risk factors they looked at, a history of prior instability conferred an odds ratio of about 2.7 of dislocation after revision, and at the 1-year follow-up, that was still about 1.9, with the strongest risk factor being abductor deficiency. So why does this happen? Why do prosthetic joints dislocate, and why does the rate of dislocation increase after subsequent surgeries? I think that these classification systems are helpful in terms of thinking about categories of etiology of instability. This is a classic paper from CORE in 1983. The so-called CORE classification system is shown here. They classified a type 1 dislocation as positional, meaning the dislocation occurred because the patient assumed a position that was outside of the stable range of the prosthesis. Type 2 is dislocation owing to soft tissue imbalance, including abductor deficiency or leg length offset, et cetera. And type 3 is dislocation owing to malpositioned components. This is a more recent paper from 2012, which offers another very useful classification system and framework for instability. The authors list acetabular component malpositioning, femoral component malpositioning, abductor trochanteric complex deficiency or pathology, impingement, and late wear as possible categories of things that can contribute to instability. And then they offer an algorithm for intervention based on that source of instability. I think in reality, several of these things can coexist, obviously, and treating one may inadvertently lead you to another. So, for example, revising a malpositioned cup, you may end up over-medializing and leaving yourself with decreased offset. So obviously this is kind of nuanced. I think as far as treatment though, and trying to prevent instability or recurrent instability, the most important thing is just following basic principles of hip arthroplasty. So this includes, being mindful of length, offset, component positioning, which can be very patient specific, head size and soft tissues. And then once all of these things are addressed as best possible, the use of adjunctive tools such as constrained liners or dual mobility. We can talk about a few of these things in greater detail. So component malpositioning first. There's some kind of classic dogmatic ranges for appropriate component positions for both femoral and acetabular components. This is the classic LeCocq paper from 1978 in JBGS, in which they retrospectively reviewed dislocations after primary hips and determined that there was a safe zone for acetabular component positioning at 15 degrees plus or minus 10 of anteversion and 40 plus or minus 10 of abduction. In recent years, however, it's been recognized that there's likely a fair bit of nuance to the practice of component positioning, which is highlighted in this paper from 2015, which kind of calls into question that concept of the LeCocq safe zone. They looked at all of their dislocations in primary hips over a 10-year period and found that half of them had appropriately positioned cups within the LeCocq safe zone. So I think the point the authors are trying to make is that stability is multifactorial, as we've already discussed, and that there's a lot of factors to consider, in that some patients' anatomy, be it their spinal pelvic parameters or underlying dysplasia, may dictate a safe zone that's outside the norm. Soft tissues and especially abductor deficiency is a huge problem in total hip. Inappropriate tension on the abductors can be due to several things, which includes technical errors with implant selection, injury to the troch. It can be due to sources of inflammation causing damage or changes to soft tissue, including infection or osteolysis. And then longer term, you can see gradual medialization and shortening due to polywear. The treatment for this includes modular exchange with head, neck, and liner exchange, and addressing the abductor mechanism with either repair, reconstruction, or trochanteric advancement, and then possibly the use of constrained liners to help mitigate some of that laxity. And impingement. So impingement can occur between any two non-articular surfaces, and it can have several sources. So over-medializing the cup can lead to impingement. Soft tissues, including scar tissue or bony sources like osteophytes, can be a source of impingement. Spine factors, as we just mentioned, can be a source of impingement, including sagittal balance or loss of lumbar mobility. And then treatment requires addressing the cause of impingement, obviously with either component repositioning, lateralizing the cup or head center, increasing head size, which leads to increased range of motion prior to impingement, and increasing onset of neck length, as well as removing any of those bony or soft tissue causes of impingement. And then once all of these principles have kind of been addressed, I think there's a number of important tools in the toolbox to help achieve instability. And this includes constrained liners. So I think these really have a relatively narrow set of indications. They're not indicated for use in the presence of component malpositioning with known impingement within a functional range of motion. I don't think they're a panacea for instability. They should be used for patients with soft tissue or abductor deficiency in whom efforts have been made to address all other causes of instability. And they can be helpful in patients who have technically good-looking hips, but who have cognitive or potential compliance issues. But there's distinct disadvantages to them. I think with added constraint, particularly in a hip with malpositioned components or underlying impingement. Constrained liners can lead to significant stress at the bone implant interface or the liner cement interface in the case of cemented in liners. And these are best used in cups that are already well ingrown for that exact reason. I thought this was interesting. This 23 people looking again at risk factors for dislocation after revision. The top panel, panel A, is the odds ratio for dislocation at 90 days follow-up, and panel B is odds ratio for dislocation at 1 year follow-up. And you can see, maybe although this is small, obviously, the constrained liners were protective against instability at 90 days with an odds ratio less than 1, and this was significant. But that lost significance at the 1 year follow-up, which I suspect reflects the fact that these work as intended until the stress, whether at the bone implant interface or cement liner interface, becomes too much if they're being relied on inappropriately, and then they begin to fail. And then dual mobility, so another tool in the toolbox, which has gained a ton of popularity and probably has a little bit of a wider set of indications. Some folks, I think, would say that all revision should get dual mobility. Certain patients with neuromuscular and hypermobility syndromes are certainly good indications. The disadvantages of these are potential for intraprosthetic dislocation, which is rare but does happen, as well as the increasing potential for volumetric wear and metal debris if you're using a metal head or liner, and just because you're adding an extra articulation. This was a continuous series of about 1,000 revision total hips in which dual mobility was used for all these revisions. They had a 7.3 year mean follow-up, and the dislocation rate was only 1.5%. The intraprosthetic dislocation rate was 0.2%. But so dislocation rate was considerably lower than in some of the other studies that I previously cited. And then the authors looked at all of those 15 dislocations in detail and evaluated for possible perioperative technical errors that might have contributed. And they found that 5 of these dislocations did have a technical error identified during review. So they concluded that while dual mobility has a very low dislocation rate, it doesn't compensate for potential technical errors, certainly. But so to wrap things up, we'll return to the case. The patient was admitted from the ED, taken for a revision of both her acetabular and femoral components. This is a clinical photo taken at the time of revision. This was the original stem, which was explanted, and you can see here, the significant damage and notching of the trunnion where she'd been impinging. And this is her final construct. As you can see, both components were revised. Dual mobility was used. Her cup was well seated prior to explant, but she was found to have only Kurtis A defect after removal, and an ETO was used to remove the stem. Wagner style to axial engaging stem was placed, and that's about it from me. I'll kick it to the panel now.
Yeah, well, it looks like, I mean, I agree with revising both parts. I don't have a lateral view to see what the version of the cup is, but the femoral stem looks like it's well fixed. It looks like there's useful restoration of length and offset, maybe slightly more offset than the other side, but that's not a bad thing in the setting of the instability type of case. I'm not a big fan of dual mobility because this is not an unreasonable indication for dual mobility in somebody who's had multiple failed attempts at revision for recurrent dislocation, although probably the very first time I think that the component revision would have been indicated, and they didn't have all those other failures. I probably would have used a large head, not a little.
Oops. Hi guys.
That was it.
Yeah, let's go back to the pre-op again.
Yeah.
So, there are a few things that are kind of scary here. One is that cup's clearly not in 40 degrees of abduction. It's, maybe 20 with a tailwind. And it does look excessively anteverted to me, although, without a CT scan, I can't say that for sure. The thing that really gives us a pretty good sense of what's going on here is the notching on the femoral stem, and that notching is happening because she is coming up in external rotation up against the back end, the backside of the cup is the most likely etiology here. And this isn't something that happened once. This was probably happening almost every time she took the step. And quite honestly, this is something where at the first revision, this is probably something that should have been fixed then. The resort to, swapping out the bearings, I think was really not fixing the problem. The case here was to change out, swap out the socket at the very least at that early stage, without getting a better sense of what the stem looked like. If it was, sort of a one-time dislocation, you could probably have gotten away with leaving the stem, but once you have a notch like that, it's got to go, no matter what.
In the op reports from her first and second revision, I think, they did note that there was a little bit of notching already. And there was nothing in any of that documentation really about kind of the decision-making around not revising either of the components, other than the fact that they said, the cup and stem were very well fixed and ingrown. And I included some of her social factors. Certainly this did not appear in any of the documentation, but I wouldn't be surprised if some of that stuff was taken into account in terms of decision-making, just to do essentially a smaller surgery on her. But obviously it led to bigger problems down the line.
Well, it's always easy to replace a patient. It's easier to, point out the patient's nuts than point out that you got it wrong. And
I could add a little.
the two are not mutually exclusive.
And knowing this patient, she has severe mental health. It's very schizophrenia that was not well managed at any point, I think, throughout her admission. She, in fact, at least claimed to sue the hospital after this revision was done because we didn't give her back her explanted implants. She wanted to melt down and sell them in Indian. So my suspicion is saying that they probably did the simplest thing that they thought would allow them to
Get her out the door.
and hopefully have a stable hip. But I think the take-home message is the revision or the strategy for component malposition is not a constraint liner or an offset liner or a lateralized liner, because revision for component malposition is component revision. So it's a malposition cup, and again, even if it's 40-15 as you described it, that's an unstable position for that patient, and that's not a safe zone.
Yeah.
So again, if I trial at 40-20 and they're not stable posteriorly, then I'll revise the cup. I'll put in the 30-degree manversion or 40-degree manversion or whatever is necessary in order for them to have a physiologically stable hip. And again, to some extent with the modular proximal femoral body, you can choose varying offsets, and I can hopefully reduce the possibility for impingement. And again, I choose not to use skill mobility as much as possible for some of the concerns you described, but I think revisions for dislocation, particularly multiple dislocations, and particularly in context of someone who has perhaps neuromuscular disorders or patient risk factors, I think those are good indications.
Yeah, but you used it here, or you went to make it? Yeah,
Yeah.
I think I would too. I'm more of a fan of them than you are, Charles. But it's not something you use in every patient. Right.
I'll pose a question. In like the patient with a well-fixed implants, we don't suspect component malpositioning as part of the problem, recurrent instability. Maybe it's older parts where there's not a constrained liner that's still available. This is, I know, kind of a little bit of a reference to a recent patient who's come in, but that happens sometimes. All right, if it's abductor insufficiency or another suspected etiology, when do you think about doing the more simple procedure of just, rather than revising the components in that situation, cementing in a constrained liner? Do you take like patient factors into consideration, minimally ambulatory, things like that?
I think if the components are well positioned and the shell is big enough to accept the cemented constraint liner in the setting of abdominal deficiency, that's a good procedure. You get a well-fixed shell, you cement something. To me, dual mobility does not help abdominal deficiency. Right? Abdominal deficiency helps by capturing the ball and fall out. If you're going to do a trowel abduction, you can dislocate it anteriorly and posteriorly, and length is appropriate for swimmer, you have a soft tissue issue, right? You can't improve that with component positions. If you move it in one direction, you're more likely to go more anteriorly, and if you go the other direction, more likely to go out posteriorly. So those to me are the best indications for constraint minor. And I know some people popularize full mobility in the setting of that, but I don't think ability, it might help a little bit in that it would take greater jump distance. So when you're sliding out, maybe you don't go all the way out, but it really doesn't, stop your hip from subluxing. Like it's not going to change that in any way. The only thing to address that is either some type of an abductor repair, use maximus muscle transfer, or adding length, making the leg longer, try to create enough tension, or some type of constraint.
I don't really have anything else to add. I was just gonna say, looking at this, even if the components were appropriately positioned, the better AP pelvis, I think there's probably slightly decreased offset on that side. Length looks like it's appropriate, slightly increased if anything. It's impinging, so you could go up on head length and see if it doesn't internally impinge, but it probably wouldn't. It would probably still would. So yeah, I think clear you have to revise.
The next button, right?
Yeah, exactly, that part too.
In the crazy face.
That neck is gonna break, and it's gonna break at the most inconvenient possible time, because that's always when it happens. It's on the tension side. That thing's about to go.
Yeah. A couple of the papers you referenced are good. I think there's been some updates to a couple of them. This one that came out about a year and a half ago from Mayo that showed that, I think they used AI or something to show that what's the safe zone and hips that don't dislocate versus do. And I think they said that the anteversion for them and the ones that don't is closer to 30 to 35 degrees. I think when they looked at it more, though, that was especially true for posterior approach patient surgeons. So my sense and takeaway from that is if you're doing the anterior approach or a direct lateral approach, for me, I think put it kind of anatomically, which is going to be maybe 15 to 20 degrees of anteversion and maybe 40 degrees. But if you're doing posterior approach, you may need to dial in a little bit more. Of course, in this case, maybe they dialed in too much, and you can see that opposite problem too, where they come out in front. So just the importance of trialing is another factor too. So.
Dave, what if you have any thoughts? So we've been talking about how to solve this problem. Obviously, it's a suboptimal X-ray in terms of offset and lengthening restoration, definitely tell. But if you look at this, we're all talking about how to solve this. But let's take it back one step. If you have any ideas for the panel about how to avoid this situation. So we talked about moving a safe zone, but how can you avoid? Obviously, the cut position is not optimized. So if you're going into a surgery with a suboptimal mental construct of the patient, you change your surgical approach, you go from posterior approach to direct anterior, direct lateral, use your best approach you have in your hands, you consider things. How do you optimize your abduction inclination and anteversion on your cut? So how do you avoid this situation if you're out there in practice, you have a challenging patient like this? Do you have any thoughts about that?
This is a problem that we haven't figured out how to avoid. That's why the most common cause for revision in medicine. But some places have. So, for example, with robotic technology, even with the posterior approach, the group of HSS has reported less than 1% risk of dislocation. Very, very, it's like 200,000 or something like that. So with appropriate positioning, you can make this a minimal issue. With using a direct anterior approach, if you use fluoroscopy and then either with or without different tools like orthogrid or joint point or whatever, that's another very active way of optimizing cut position. And it also allows you to see offset and length restoration. Preoperative templating is a very good way of getting appropriate offset and length restoration. But I think one of the biggest things is a good intraoperative assessment of stability, because that takes into place not only the component position, but also your soft tissue tension and whether or not there's osteophytes or impingement that you haven't addressed. I think that's one of the reasons why some of these studies see dislocations even in quote safe zones. What was considered safe zones is because they're not taking into consideration osteophytes or soft tissues that were left that are impinging in certain places, or situations where the adductors are deficient in certain cases. Those people are going to be at risk for dislocation regardless of positioning. And then you add the whole spinal pelvic issue, and
these matters, so. we
So
talk
to
about
what
that.
degree then are you relying, say, on your shuck test, and how do you teach a shuck test to residents in training or fellows in training? That's a whole field that senior surgeons can develop, but it's hard, right? So that's where you have to think about other constructs that can come into play to help you dial in your hip.
I don't even use a shuck test unless you're talking about something that's so ridiculously loose, because I think when you're using a shuck test, you're really when your anesthesiologist, the amount of relaxation you have.
Exactly.
And if you try and make your shuck test tight, you're gonna make a lot of legs very, very long, and a lot of unhappy patients, so I do a trial reduction, and essentially, if I can dislocate it both anteriorly and posteriorly, that tells me that I haven't restored length or offset, or there's an abductive issue. If there's no reason, there's no way for me to improve one position and make it more stable in both directions. Right, so, but I think your trial reduction is important, and then I think your component position is important. And, there's the concept of combined anteversion that some people feel is appropriate. I'm not as big a fan of combined anteversion, because I don't think you can retrovert a stem or retrovert a cup and put, let's say, you retrovert a cup 10 degrees and you antevert it 45 degrees. That's not good. That's not a good solution. You're still gonna, okay, so I think within reason, you can slightly increase your anteversion of your cup if your stem is slightly less anteverted, let's say, because the native version is less. But I think if you go with the extreme, that I don't think works. I think another issue is approach. I mean, posterior approach has higher dislocation. That's that's just a fact. What I suspect probably happened here is done through a posterior approach.
I think it's pretty louder.
Yeah.
Oh, that's okay.
Yeah.
So, oftentimes what you'll see is somebody does a posterior approach, a little bit unstable, so they can't cover the cup, and you're sort of robbing Peter to pay Paul. This is one of the reasons bigger heads have sort of come up, which is, it's to reduce the risk of a dislocation. But then the problem is every time you introduce a new technology, it's a problem. The shock test, I don't think is terribly useful. It depends on how heavy the leg is,
What direction?
what you had for breakfast that morning, whether you had an upper body workout the day before. I mean, so many reasons why that really isn't terribly helpful. For me, unless it's a dysplastic hip, I'm going to try and put the parts where the anatomy started out to the greatest extent possible.
I think it's worth mentioning for all the young doctors here, and we've been doing this for a long time, so we can have a pretty good feel. But it all starts at patient selection. I wish we could see the pre-op image, because in this patient, I would try not to operate on this knee for a lot of reasons, right? So patient selection is key, right? And then the pre-plan, all of us old guys started off with this two-dimensional planning, these markers and all that stuff that you have to do with resident fellow. Things have changed. It is comments. There's now more ancillary things to help us, different surgical approach choices, different ways to dial in component orientation, looking for diversion, all these things keep you out of trouble.
Yes, I guess Sean's making a good point on this. We don't have the pre-op film, but I'll bet this was not an easy hit. Look at the other side. It's a pretty deep plastic hip. So that's the key to help the registry lesson. In a case, well, this one maybe doesn't look so terrible, but when you get into surgery, trying to get the coverage, it's going to be a little disconcerting. If you could end up doing a reasonable job, if they're reaming deep enough, things like that. My gosh, that is a pretty vertical and pretty darn shallow cut to start with, and it didn't come out looking a little off. Really decent effort, so awareness of your face start.
Speak from someone who does those placements, but in a practice, those trauma surgeons do some arthroplasty. The key for me in trying to improve my technique for the residents, is learning from everyone that I've worked with and do work with, and asking questions and having multiple ways to assess
waist measures and ground. So what I might do is have that. Leg waist. Measurement of my neck cut, and look at the trial that I have in, and if I have questions about it, I can start the vector. It's having multiple ways to start that, particularly the skill. Not just relying on one assessment, because you'll fool yourself, then you won't go back. If you have multiple assessments, some more accurate measure of whether it's like for offset, like maybe question it, if people are well, I thought it was correct.
So I just had a quick comment. Great presentation, Madeleine. These are difficult patients, and we've all of us who do this a lot have seen some of these. And after everything is optimized, your mechanics, your normalization, everything is optimized, and you're thinking about using some type of a bearing surface that might help you be more stabilized. So you have options of large diameter femoral head, dual mobility, and constraint liners. And over the years, back in the day, we used to use constraint liners as our only option. I've become a little bit more of a fan of dual mobility. And in a lot of these, there's one practical reason, and that is none of these solutions are perfect. And if you do it, it's important to do a trial range of motion with your trial components in place. You'll find that constraint liners impinge pretty early. And that's the way they fail. And I've become less a fan of constraint liners, except for certain situations where there's there's no soft tissue. But the dual mobility bearing doesn't impinge quite as early. This is why I like them. And if you have a patient who lives in some podunk, and they're a problem patient, and they happen to, despite your best efforts, fail, and they dislocate. And there are some little ER somewhere, and they dislocated their dual mobility bearing. Well, the doc could probably reduce that. The thing might come apart, and you have an interprosthetic association. But if you have a constrained liner that fails, you have a surgical problem that can't be dealt with until you take it to the OR. And so that's just a practical consideration to think about sometimes, that you have some time to deal with a reduced. A dislocated dual mobility that's been reduced, even if the poly fell out, you can do it semi-electric. Whereas you have a constrained liner that's broken and sitting out there, that's all of a sudden kind of an urgent problem. So just a practical consideration.
I would say most dual mobilities that we've seen at our place dislocated, if they weren't an interprosthetic dislocation to start, they became the right. So it's, I don't think people have been as successful in reducing dual mobilities as we think.
Yeah, but at least it's temporary.
Yeah, Madeleine, a couple of other comments. So for one, that's not a great AD of the pelvis cut. So we have to be careful with making any assessment. It's sort of an operator will think of the right hip. And the other reason I think that's not just because that coupler is, hugely oversized. I was going to say I have had success with dual mobilities in people with deficient abductors, and I wouldn't leave the OR with that construct in there like Mavin's talking about without really convincing myself. But I've done them in a few tumor cases where there was no medius. I've done them with pseudotumors that have completely eroded the medius. One of these patients was a 350-pound woman who was incarcerated for dealing methamphetamines, and hers has been, stable for 6 or 7 years now. So I think there is a role that's poorly defined to use the people with deficient abductors. And my feeling is if I put a constrained liner in that 350-pound woman, I just can predict that is going to fail, within some, few number of years. One other thing, Paul. Two old surgeons here, both primarily use the posterior approach. I think we would contend that our dislocation rate is exceptionally low. And there is some, you can find studies for anything, but I think there are plenty of studies that find at most a very subtle difference in dislocation rates between the different interior and posterior approaches.
I think I mentioned yesterday, so we put this study, direct answer versus posterior. 0.9% dislocation rate, so zero difference. But in our hands,
DA could make a difference for people that exposed to spinal fusions. If they exposed to spinal fusions, exposed to 4 point something percent dislocation. DA has done. Now, it wasn't huge numbers, but it's, I think in that setting, being able to assess the composition relative to the pelvis position or, I think it's advantageous. It's trickier. Yeah, it's trickier.
Why don't you, I know we have to move on. One last comment I was gonna say is kind of, I don't know if the gentleman say off there left, but I think that the ancillary technologies are great, but I would say, you know, if you're for the residents, I think like Dr. Lack said, it's probably best to think of a combination of things. And I think stability testing is really important. You know, not to, you know, the modern method with the DA is to use fluoro and to match the anatomy perfectly to the other side and do the cup in 20/40, roughly, match length and offset. And that's probably great 98% of the time. But if you don't do any trialing, you may miss something. So, and you still can trial on a table. You just, you know, not perfectly. It's easier to trial if you're doing tableless DA or something. But I think that there is definitely some utility to doing shock testing, different stability testing with an anterior approach, and not rely on one technology. I think you can use all.
I think one point that's really good for the residents is that if there's any question on any type of case, it never hurts to get an intraoperative X-ray. So you can always correct things a lot easier before you leave the room than you can after. So particularly when you're early in your career, you have less experience, it never hurts to get an intraoperative X-ray or a X-ray before you leave the room. When you're talking about trauma points or anything.
It's not a complication of putting your operating. Most I have said that to me, but we're injecting rotation around for enabling it. It's similar. I mean, you can have a patient that drops it, they obviously, but playing positioning for doctor from positioning. You can correct it so in that case, it makes for a longer case, but that's a lot better than comes back. You have any doubts, get an X-ray.
One comment kind of similar to what Dr. Crutcher was talking about, the risk of intraprosthetic dislocation with potential reduction in vertical mobility components. I think we've had some like QI emails about that, but pretty good idea to get a CT scan after, especially an unsuccessful reduction, even a successful one or potentially successful one as well, where that may be under recognized that intraprosthetic. Yeah.
Plastic, you can't see the plastic, so it's bigger, it's fine. It's somewhere up in the abductors.
All right. Thank you.
Yeah.
Good morning, everyone. I'm Arthur McDowell. I'm a third-year resident at the University of Washington, and I'll be presenting my presentation on acetabular bone loss. Dr. Nelson gave a really good presentation yesterday on total hip arthroplasty revisions, where he covered some of this topic, but I'll try to be a little bit focus a little bit more on the classification of bone loss in this presentation. So I have no disclosures. And in terms of this presentation, I intend to cover a quick case, give some background info on acetabular bone loss, describe the most common classification systems, as well as the treatment, as well as some technical considerations with surgical planning, and then a quick panel discussion and case resolution. So to start, the patient that I'll be presenting is a 69-year-old woman with a complex medical history, which is significant for ulcerative colitis, who's underwent bilateral unsubmitted total hip arthroplasty for avascular necrosis after high-dose steroid treatment. She initially presented to our clinic for her right side, where she had already undergone a total hip revision. But in terms of this presentation, I'll only be focusing on her left side. In regards to this, she had intermittent worsening left hip pain for greater than a year, as well as decreased function and mobility. She had previously been a community ambulator and not using a cane or any other assistive device. In terms of her other history, she had a history of psoriasis, hypertension, and as well as a right trochanteric bursitis. And she was on immune modulating medication with Humira, and she took about 90 milliequivalents of morphine. And so in terms of her physical exam, she had a leg length discrepancy of 1 centimeter, where her right leg was actually shorter than her left. And her range of motion was pretty decent on the left side with 0 to 90 in flexion and extension. And she did have internal rotation of 60 degrees. However, she had no external rotation beyond neutral. Additionally, in terms of her history, she had undergone a right total hip arthroplasty in 1986. She also underwent a cord needle decompression that year for that side prior to that. And then in 1990, she underwent the left total hip arthroplasty. She did well initially until she complained of right hip pain, and she presented to one of the partners here at the University of Washington, and she was found to have aseptic loosening and of her acetabular component due to osteolysis, and she underwent a revision for that. She additionally sustained a distal femur fracture and underwent open reduction internal fixation on the right side. And she had 2 additional surgeries with irrigation and debridement. She had developed inflammatory bursitis over her right trochanter. In regards to her presentation, these are her initial films of her AP pelvis. Again, I would be focusing on the left side. However, in terms of her right hip, she had a pretty large trabeculoacetabular shell with some protrusion and bone loss, even after the right total hip revision. On the left side, her hip joint appears to be a little bit more concentric in terms of the prosthesis. However, she had the long stem, on the right side, a long stem femoral prosthesis with the plate for distal femur. In terms of her left hip, on radiographs, you'll see increased superior migration of the cup with marked osteolysis surrounding the acetabulum. However, the femoral component does appear well fixed. In terms of her initial workup, just to ensure that there was no infection, her labs, as demonstrated here, she did have an elevated CRP and ESR at that time. She was also found to have a UTI concurrently at that visit, as it was sent by her primary care provider a week prior to her visit with us. She did have her hip aspirated prior to undergoing the left-sided revision, and her cell count was only 95, cultures were negative. So at this time, I'll move on to background about acetabular bone loss. So in general, primary total hip arthroplasty is projected to grow significantly by 2030. There are multiple different percentages and values, which we'll kind of see over time. However, more primary total hip arthroplasty being performed also in younger patients with more broad indications, which has made this become a larger issue as these are becoming more complex as these patients are living longer, as well as the implant longevity is also improving. In terms of the most often diagnoses of why patients get total hips, we'll hear about some of these today as well, but aseptic loosening is also common: fracture, instability, infection, and severe wear. In terms of revision of the acetabular component, you usually will have some degree of bone loss with many of these diagnoses. However, the degree of bone loss at time of revision usually can be used to dictate the type of reconstruction that's necessary. And so I'll start by talking about one of the earlier classifications, which was first introduced by D'Antoni in the late 80s, early 90s. This classification has been modified and is commonly used by the AAOS. And this classification is mostly based on the actual appearance of the acetabulum and the deficiencies, with most of it being centered around cavitary deformities as well as pelvic discontinuity and arthrodesis. In terms of the most commonly used classification, however, as mentioned yesterday, many of the surgeons use the Prabhaka classification, and this is based on the amount of hip center migration and the integrity of 4 acetabular supporting structures on a preoperative AP pelvis. The first thing that's examined is the Kohler line, which you can see in blue, as well as the osteolysis teardrop, as you can see with the arrow in red. Superior migration of the hip center, which is being marked by green, and osteolysis of the ischium, which is being demarcated in yellow. In terms of this classification, it's divided into 3 types with increasingly severe degrees of bone loss. Type 2 and 3 are further divided into subtypes. Type 1 defects have minimal focal bone loss with maintenance of the hemispheric shape of the acetabulum. The supporting structures, including the acetabular walls and columns, are all intact with no hip center migration. In terms of type 2 defects, there's usually moderate bone loss with deficient walls but intact acetabular columns and less than 2 centimeters of hip center migration, which is what demarcates that from type 3 defect. In terms of A, B, and C classifications, this is all related to the wear as well as component migration of the acetabulum. With type 2 and type 3s, you're usually evaluating the columns to determine the type of fixation that you can use. In terms of type 2A defects, they have a global cavitation of the acetabulum with direct superior hip center migration, which is sufficiently intact with superior dome and teardrop, preventing concomitant lateral or medial displacement. In terms of type 2B defects, these are characterized by a deficient superior dome allowing for superior and lateral component migration owing to the lack of a lateral stabilizing buttress. Type 2C defects have a deficient medial wall, which can be demarcated by the teardrop, osteolysis, and you can see direct medialization there. Sorry about that. In terms of type 3A and 3B, the type 3A defects, usually you see a up and out acetabular displacement of the prosthesis with superior hip center migration. And with type 3B, you'll see medialization with some protrusio. And this can also be seen with some pelvic discontinuity with disruption of the acetabular columns. In terms of the validity of the Prabhaka classification, there's a systematic review out of HSS where they review this classification and another, as well as the AAOS classification, to just look at how well this is studied in the inter and intra-observer reliability. In terms of the Prabhaka and the AAOS acetabular bone loss classifications in 4 different studies, they were considered to be unreliable in 75% and 100% of studies, respectively. This, however, is of some contention and debate in other studies, as some have found good inter-reserve reliability. In terms of the Prabhaka classification, however, femoral bone loss has been demonstrated to have pretty good inter and intra-observer reliability. In terms of initial evaluation, AP pelvis as well as lateral radiographs are initially used to assess the amount of femoral acetabular bone loss. Judet views can be useful in evaluating the acetabulum and pelvis structures to better appreciate any further bone loss that may not be appreciable on an AP pelvis. In terms of other imaging modalities, which has been mentioned in other presentations, CT pelvis can be useful. However, there can be extensive disruption of your ability to appreciate the bone loss just due to the metal artifact. As well, a CTA can be used to evaluate for the location of neurovascular structures, especially with type 3B Prabhaka acetabular bone loss. In terms of treatment, which I will not go into great detail, there are many different options in terms of treating acetabular bone loss. The standard of treatment, usually for Prabhaka 1 and 2, acetabular bone loss, is usually uncemented hemispherical cups. You can use bone grafting to help with any medialization, as well as deficiencies. In terms of Prabhaka 3A and 3B, there are multiple other options where you can use either a jumbo cup cage reconstruction, a cage with structural bone allograft, distraction, as well as anteroprotrusio caging, and triflange, which all three of those can be used for pelvic discontinuity, which has been shown in multiple studies to have reliable outcomes. However, triflange is probably the least used, as mentioned by Dr. Nelson already, for a couple of different unsatisfactory results in terms of outcomes, in terms of dislocation and other things. In terms of preoperative evaluation for these patients and anything in terms of arthroplasty, you want to make sure that you rule out any infection early on. You want to get a good physical exam to evaluate for any weakness or deficiencies, especially evaluating for gait patterns and limb length discrepancy. Another thing that you want to think about when planning for these is the surgical approach. Oftentimes, these patients have either had a posterior, anterior, or a lateral approach, and sometimes these can be extensile, and the need for better insertion of larger implants may be necessary. And so you want to make sure that you can visualize the acetabular rim and the posterior and anterior columns well. So you want to make sure that the approach that you're using is adequate in these revision cases. And so the goal of reconstruction for these procedures are to restore the hip mechanics, reestablish osseous coverage with new acetabular component, and as well as augments, as well as to achieve rigid fixation of the acetabular component. And sometimes you may need to use grafts, augments, or other types of prostheses. So in terms of this, for the panel, I will pull up the images again, but how would you approach this case, and do you have any special considerations?
Yeah, so we're talking about the left hip.
The left hip, yes.
So I mean, this is not super complicated, I don't think.
Yeah.
There's a good teardrop, there's a small amount of additional lysis. You can put a shell at the normal hip center and then use an augment laterally. It's not a 3B. There's not a pelvic discontinuity. There's bone medially, and you got to make sure you medialize all the way to the teardrop. You got to make sure you get some inferior hemispherical fixation. You need at least one screw is the issue, or a couple screws is the issue, and then you need some screws into the ilium superiorly, and then you can use augment. I would put the cup in first, and then I would put the augment in after I put the cup in it, and it may be one where you slide the augment in its normal configuration, or maybe one of those flying buttress grafts where you reverse it. It's depending on what fits better after you put that in. Assuming that stem is appropriately anteverted, you don't need to revise that femur as long as you have an appropriate implant. Hopefully, if you bring the cup down to its normal center, it looks like that leg is already longer than the other leg. The teardrop looks like it's in a reasonable position. So hopefully, if you bring it down, you can go away from that skirted head to a standard non-skirted head to enhance your stability. And I would use the largest head I could use, and probably did not improve mobility or strain or anything like that.
Yeah, I mean, not a whole lot to add. I would agree with, probably same thing. I'd probably just get some 2-day views to start with to assess, what's going on a little better. But I would do the exact plan for the exact reconstruction.
Is that my hip on the right?
It is.
I think spoils results of follow-up. So, I'm not sure I would necessarily get a CT scan here in terms of preoperative planning. A Judet view would definitely be helpful. I think it's 100% guaranteed that your bone loss is going to be substantially worse than what you see on the X-ray. I have never ever seen a case where the bone loss is better than what I expect based on the X-ray. In terms of construct here, as Dr. Nelson pointed out, you've got a pretty good medial and inferior bone present. I think this would be a hemispherical cup, augment if needed. On the stem, my concern here would be when this was put in, it was put in with a long skirt, which implies that they had some sort of problem, okay, with stability. This is a partially coated titanium stem. I would have a low threshold for taking this out if I thought there was any question about position or level of instability. But otherwise, hemispherical cup would be the go-to here.
So, yeah, I know what was done, and, again, I think that plan, well, alluded to was ultimately was done here, I'm sure Arthur will show. Subsequent.
We'll figure it out.
But,
Nothing tells me the story isn't over.
yeah, it's not over yet, but one point I'll make, I suppose, and maybe point especially maybe in hindsight. So if I can get me on up, if I feel I have column support, and if I feel I have multiple screws and multiple planes, in particular multiple planes, good fixation, and I rarely leave an augment, even with 30–40% uncovered superiorly, I don't know if that always adds a lot of mechanical stability. In some cases, I think it might. The other point that was important that Ross talks about, but maybe it's not as described, as the health of the residual bleeding bone. You can have tack columns. I think part of the problem with this patient is that her protoplasm, the health of her bone, the breathing with a couple of 30 years ago, I would suspect this was loose for many years. Fibrous tissue is not healed to an implant, so you have to have at least 3% healthy bleeding bone to surface implant with that cup, and you have to have the stability, mechanical stability, biological stability. So again, you'll see ultimately.
She had no previous radiation or anything.
Not that I recall.
Right, so I mean, in the
Yeah.
absence of radiation,
Yeah.
almost the acetabulum has some of the best blood loss in the body, the blood flow in the body, right? So, the only time I see situations where I worry about biology of the acetabulum healed with the device, especially a highly porous device, is with previous high dose radiation where, they used to use for cancer in the old days.
I agree it's not common, but it's still an important point.
If I remember correctly, though, this lady is pretty malnourished.
She is.
Yeah, her BMI is like 15 or 16
Yeah.
or something.
Yeah, okay. So there's some probably pretty significant hypoalemia going on here. This lady's not gonna make her protein too well.
And so Dr. Nelson already answered the second question, which is, do you prefer fixing the augments first if you need to use any augments before you place your final cup? And then the third question I have is, when addressing pelvic discontinuity, which isn't this case in particular, but do you have a preference in your reconstruction methods or options?
So I think it depends upon the type of pelvic discontinuity. So we talked briefly yesterday about the three options people have described. So Crosby talks about using distraction to stabilize it. There's some studies out of Mayo Development of the cup cage, and there's been a number of studies with custom triflanges, and all of those techniques have worked for chronic discontinuity. They're essentially not given acute discontinuity, like they see at Harvard, right? So that's an acute fracture that you can plate and then just put a cup in. But the chronic one, you're probably not going to go get it reduced properly because it's essentially a non-union, not a. If you start taking down the non-union, then you destabilize it and you make distraction and those other techniques less effective. So, my preference is usually a cup cage for most of them. I think that's the technique that's worked best in my hands.
And so for case resolution, in terms of this patient, she underwent a revision total hip arthroplasty Using a direct lateral approach, she had a trabecular metal jumbo multi-hole cup placed. As Dr. Fernando alluded to, she had not such great bone stock still, even though this was not like a 3B. So this was the implant of choice. And so despite this, you also see that she had cerclage wire placed over the trochanter because she also was identified to have a greater trochanter fracture there as well. And so this was her final construct at this stage. I didn't include it, but she had multiple other complications. And the left side, actually, she went on to have failure fixation and she went back for another revision. And the right side, she was found to have an infection. So she had an explant and she subsequently did not get a reimplantation because she passed away. So these are my references. Thank you.
Thank you, sir. All right. Hello, I'm Zachary Mills. I'm one of the third-year residents. So happy to be here this morning. I know we might be running behind just a little bit, so I'll try to keep things relatively succinct. But I have the pleasure of presenting on Trunnionosis this morning, an interesting topic, and one that has relevance certainly to what we've been talking about thus far, but fortunately for me has not been discussed so much up until this point. So to start off with our case, we have a 97-year-old male. He has history of a left total hip arthroplasty at an outside hospital back in 2010. Was doing well, but has had multiple episodes of dislocations and presents thusly. His medical history of a recent TAVR, chronic kidney disease, anemia, and then surgical history also of a right-sided total hip arthroplasty and bilateral total knees. Presented to our clinic originally on December 2nd of 2022, at that time again with a history of 6 dislocation episodes. Those had happened primarily between June and September of the same year, and he hadn't had any recurrent dislocation since September. He came in wearing an abduction brace. He came with also a Mars MRI, which demonstrated adverse local tissue reaction. And at that initial visit, we planned for him infectious workup with white blood cell count ESR COP, which returned normal, and also demonstrated elevated cobalt levels of 3.9 and chromium of 1.1. Here are his initial x-rays with which he presented. Again, we're looking at the left side here. Overall, the implant looks reasonably well positioned, well fixed. There's some heterotopic ossification seen laterally to the joint. Here's the imaging that he presented with. Again, this is the metal reduction MRI. Demonstrates multiple areas of adverse local soft tissue reaction, but very significantly, there's a lateral, posterior lateral area that shows a pseudocyst or cyst formation with mixed tissue components. So again, our topic is Trunnionosis. This is a condition of degeneration at the head-neck junction. The primary mechanism by which it's proposed to occur is mechanically assisted crevice corrosion, or MAC, with 2 C's. This is corrosion, again, occurring at that head-neck junction. But of course, we know that corrosion can occur at multiple places in total hip arthroplasty, and really it has to do with areas of contact or modularity. Before we get too into that, though, I think it does have to be addressed what this joint is. It's a Morse taper, which is a trunnion and bore or cone and cone taper, as seen in these pictures. Originally developed by Stephen Morse in 1864 as an engineer used in machining components, in machining tools. You can see a more classically designed Morse taper up in the top corner there. In 1974, it was implemented for the first time in total hip arthroplasty by Professor Heinz Mittelmeier in Germany. He implemented the Morse taper at the head neck junction here due to a problem in the use of ceramic heads, that there is a high rate of ceramic head fracture. where they had been previously glued into place or screwed into place, he implemented this Morse taper to try to provide a reliable intraoperative method of fixation that could reduce stresses leading to fracture. Subsequently, there's wide adoption of this due to its, again, reliable ability to obtain fixation intraoperatively, and again, with the expansion of modular design and total hip femoral components. However, with the implementation of the Morse taper, there has been non-standard usage of the design in between different companies, industries, and devices. The taper can vary widely in the way that it's designed. There's 4 primary measurements: the taper angle, the primary diameter, the secondary diameter, and the length. Those measurements have some importance in the stability of both the joint and the trunnion itself, and as previously stated to this point, don't have any standardization in practice. So with this understanding of the Morse taper, then we can discuss a little bit fretting and corrosion as they occur at this modular junction. Metals in the body create, and metals in most areas in the world will create a protective oxide layer when exposed to oxygen, or the oxygen that's in solution in our bodies. This oxide layer is developed in a process called passivation, and the oxide layer provides a corrosion resistant surface on the metal within the body. This helps decrease reactivity, decrease rates of corrosion. However, the form of this passivation layer can be complicated mechanically by fretting and by a number of different methods or modalities of corrosion, including fretting corrosion, but also crevice corrosion and galvanic corrosion. Here, this diagram just helps to provide a visual aid. You can imagine that with metal reacting to oxygen in solution, this kind of a protective layer forms that helps prevent more metal being drawn from the component and further reactivity. So first, looking at, again, the more mechanical process of fretting. Fretting is aware of surfaces in contact with one another under cyclic load with micromotion, not macromotion. That disrupts that passivation layer and exposes fresh metal that is not had oxide formed on it. This also can create debris of the oxide passivation layer or of the underlying metal. As fretting occurs, the new surface that's exposed reoxidizes, again, taking oxygen from the environment. This cycle can continue and become increasingly severe as the amount of debris increases, the amount of abrasion increases, and the amount of freshly exposed metal increases. Although this is described in the mechanical process primarily, there's also a corrosive process that occurs within fretting, which would be the loss of metal to oxide or to dissolution as it's readily exposed to the environment. Thinking more about types of corrosion, crevice corrosion can occur separately, but is intimately involved in the process of fretting. As either crevices form through processes like fretting, fatigue, or as they naturally exist after the machining of materials, a gradient in oxygen tension can form within the crevice itself with poor flow and poor exchange of oxygen through the electrolyte. As this gradient forms, a potential difference occurs and the passivation layer cannot be created within the crevice. Again, this means that the metal itself is more exposed to the environment and that it can fall into it can dissolve or go into dissolution, thus resulting in corrosion. Again, this is something that tends to kind of cyclically occur and worsen, where the pH in that crevice can get lower and lower, again, resulting in more and more reactivity. And then finally, a separate type of corrosion, not necessarily exactly part of the MAC process, but certainly relevant whenever we think of multiple metals or even one metal in the body. Galvanic corrosion is an electrochemical process which occurs, you probably remember this from your chemistry or physics class in high school, when two metals are in contact electrically in electrolyte solution. Electrons are stolen by the less reactive cathode, and this results in dissolution of the anode metal, meaning that the anode goes off, its ions going into solution. So now with this basis of mechanical fretting and corrosion, we can talk a little bit more about Trunnionosis. Trunnionosis accounts for approximately 0.7 to 3% of all total hip arthroplasty revisions. Incidence may be increasing, or recognition may be increasing, or a combination of the two may be occurring, but this topic has certainly come into greater recognition in recent years. This is due in part to a number of factors, including those related to the implant. Some of the most frequently cited implant factors include larger femoral head designs. As we've talked about extensively, a larger femoral head, as depicted here, can increase jump distance and decrease rates of dislocation. We love stability, we hate instability, and so there's been a great impetus in pushing for that in design. Larger femoral heads, however, also increase the moment arm to the trunnion neck and thus increase forces and torsion at that area, increasing micromotion. Other things important in contributing to this are smaller trunnion sizes. We talked about all of those dimensions. Previously, as femoral head sizes came down, the sizes of necks and trunnions went down. And as femoral head sizes have increased, the neck sizes haven't really increased commensurately. That means that there's less stability of the neck itself, or of the trunnion itself. And then finally, implant design. As different metals are used, this can impact the stability at the Morse taper. This can also impact the corrosion resistance. But importantly, there's also some other factors beyond implant factors. This can be surgical factors with the application and surgical technique of the head, and then and taper cleanliness, which we of course try to account for. Furthermore, there's patient factors with implant age, obesity, and activity level all having possible contributions to the development of MAC or trunnionosis. Patients with trunnionosis can present variably, and it's important to keep this on your differential when people come in, especially after a successful postoperative result with a subsequent change to their status. They can present as ours did, with instability, or they can more classically present with pain, with a limp. Importantly, investigations early on should consider likely differentials such as infection. But of course, when we have suspicion, we should obtain labs to evaluate this, and that would be cobalt and chromium. These classically, cobalt will be at a higher rate. This is due to the propensity of chromium to fall out of solution. A helpful tip for the residents, as it was always hard for me to remember, is you think things are plated with chrome, and chrome falls out of solution and becomes deposits within the body. And so as chrome comes out of solution, cobalt is the thing that we really see elevated in serum levels. And then finally, imaging is incredibly valuable. Of course, plain radiographs to assess for any number of possible complications, and Mars MRIs can help us to assess for local adverse soft tissue reactions, including pseudotumors. For the management of trunnionosis, there's really two primary directions that I'm aware of, which would be either observation or revision total hip. Observation is sometimes an appropriate method of management in folks who are lower demand, who have relatively mild symptoms, but it has to be taken into consideration that when observing, levels of serum metals can increase in the body, and there's reports of toxicity secondary to this, including neurotoxicity, cardiotoxicity, skin lesions, and a host of other things that are reported on a case report sort of basis. In considering revision total hip arthroplasty, a number of studies that have helped direct the way that these revisions are conducted. Primarily, this came from retrieval analyses. This one by Kurtis et al. Helped to assess the impact on heads and necks, and found that exchange of head and liner is almost always indicated. There's more significant metal loss and corrosion, usually at the head relative to the neck. And of course, these are modular components that can be easily replaced. This study did also point out that ceramic heads had significantly less material loss when compared to metal heads. Other retrieval analyses, including this one by LeCocq et al., discuss the use of titanium sleeves around the neck. Of course, the neck is not always modular, and when fixed to a well-fixed stem, or when part of a well-fixed stem, potentially would require much more in order to revise. And the development of titanium neck sleeves has come about, which go over the corroded neck, creating a new non-corroded surface to interact with the newly implanted head. When these modes of revision are not sufficient, then we start considering things like the revision of the stem itself, or certainly if there's gross failure of the neck, as we saw in the previous case with impingement, revision of the stem would be indicated. Outcomes after Trunnionosis have further directed both our treatment of these patients perioperatively, post-operatively, and also the way that they're treated in terms of their revisions. Overall, there's not a great deal of study on this, as we're studying patients after their revision for metallosis or for Trunnionosis related complications. And the studies do tend to show high rates of major complications, including instability and infection. This first study, well, all of these studies are retrospective case series reporting on in between 20 and 40 patients or so. This one here showed 27 patients, 18 ultimately followed up at 2 years after revision for Trunnionosis, showing decreased serum levels of metals. So we're getting rid of that toxicity, which is great. But one case here of prosthetic joint infection, 2 cases of instability requiring revision, and improvement in hip scores and Harris hip scores from the mid-50s to an average of over 86. Another retrospective case series, this one with 27 patients at a minimum of 6 months, again after revision for MAC. These folks again found high rates of dislocation with 6 out of 27 patients, and 3 of the patients experiencing deep infection after revision. Still though, on average, much improved Harris hip scores with 74% achieving over, a good or excellent outcome by that outcome metric. And then finally in this retrospective case series, we looked at 39 patients with 40 hips, again, finding decreased levels of metal ions in the serum after revision, but high rates of dislocation with 6 out of 40 patients experiencing that, and 3 out of 40 patients experiencing infection. So I'd like to open it up to our panel now. Please just take this as a general guide. I'm interested to hear whatever topics you may find most interesting or relevant in the discussion of Trunnionosis. But I wonder if you feel that there's been a change in incidence or more so recognition, or if it's really both. I wonder about the trends in operative management, the use of neck sleeves, if they seem to be, a low cost, low downside intervention at this time, but I wonder if there's a possibility of better, maybe more durable modes of addressing the issue that don't create a new metal-metal interface between the sleeve itself and the neck. Timing or considerations in stem removal. And then of course, the management of adverse local tissue reaction is variable, and I'm sure that it's complicated on a case-by-case basis. I wonder also about the direction of possible implant design changes that could occur due to this.
So it's a very, very interesting topic. And I think it was not recognized as much previously. So people had unexplained pain, and they were basically left with unexplained pain. And I think since the Rush article, there's been a little bit more attention, and people are finding more cases of taper corrosion. This is an interesting case because you're showing a modular neck, but that modular neck is titanium, it's not chrome cobalt. And the chrome cobalt in this case must be from the head. So it must be a chrome cobalt head in this situation. Now, there are also cases where you could have a ceramic head on a modular taper. And that modular taper sometimes is cobalt, chrome, and titanium. And that has been a higher rate of incidence, a recall component that has issues with taper corrosion. Not, well, I guess, modular sleeve corrosion. But I mean, this is a issue, and what I would say is that these folks who have taper corrosion, they have much more significant adverse local tissue reactions at much lower metal ion levels than metal people. So if you look at some of the metal work out of the UK, they started worrying at a ion of cobalt levels of greater than 7 parts per billion. And a lot of these folks, they'll have pretty significant adverse local tissue reactions in the 3 range. And I think that's part of the reason why there's these rates of instability and infection, because this can result in significant abductor muscle damage. And this is something that is under-recognized. I think people have moved more towards ceramic heads because of that. So that's one change that has been made. I know there's at least one company that is, it's not a major implant company, it's a smaller company, but I know there's one company that is at least looking at, they have a process of essentially chemically bonding a ceramicized surface, not oxidized, but a ceramicized surface to titanium heads. And feel that with that type of process, you don't have the issue of breakage, and you can create a taper that would avoid these types of corrosion. You can have the same type of metal, so I don't know if that as far as changes in implant design, that may be something, but again, that's a whole FDA process. It's that other stuff. So as far as operative management, most of these, that's the taper does not appear to be so severely corroded and damaged that you can't use a titanium sleeve with a ceramic head. So most of these are addressable, and ion levels usually go down with that type of a revision and most of those patients as well. Sometimes, particularly like with the old accolade, original accolade stem, some of those tapers put it down to what they call birthing, where you can't put a new sleeve on them. So there could be very, very severe damage. And the other implant that can be a concern is the Astron device has an 1113 taper, and there is no sleeve for an 1113 taper that is made. There is the tube makes one plus 0.28 millimeter head that has a sleeve built into it that you could use, but there's no ability to adjust length, offset, anything else. And again, it's a very small head, so to me, it's almost irresponsible when you consider that the ASR was put them out of business. You've got a lot of large head metals that there's really no way for somebody to revise and have adjustability with titanium sleeves in those situations. So, but
So that's the exact case, I think, concrete perhaps, ASR, large metal head, that's wrong stem. What would you do? You put a metal head back on or a ceramic head on?
it's a problem. It's if you put a ceramic head on a used taper and it fractures, that's your fault, right? If you put a metal head on and somebody who already had elevated metal levels, that's not great, right? So if it's a short stem, I would see if I could disengage it and revise the stem and leave the sleeve. But a lot of times it doesn't disengage. So then you're kind of stuck, so what do you do? And I probably in that setting would put on a ceramic head and basically let the patient know, document the crap out of it, and let the patient know it's because of the company. There's a problem. They just respond, so. But it's to me, it's unbelievably irresponsible. Now, there is a 1113 sleeve that you can get from Europe that you have to have you have to do education to use that can fit, that you might be able to solve that problem, but it's a problem.
Was the trunnion damaged in that case?
It was moderately damaged. And I was Trunnionosis at that junction also. So I used a metal head.
I would think, if it wasn't damaged and it was ASR, I would feel bad putting a metal out. If the trunnion was fine, but I guess it was different, but.
And cleaned it, which
Stuff, tough call.
So there are a few issues, just back up a little bit. One is that not all 1214 tapers are the same. They differ company to company. They actually differ within companies. So for example, Zimmer manufactures implants in the United States. They also manufacture implants in Europe. The European tapers are different than the American tapers, even though they both say they're 1214. So, my thought is that this is something has probably seen us for years. We just haven't seen it. But I do think that the incidence has increased as we've gone to larger and larger heads. And the reason for that essentially is that if you have a smaller head on On a trunnion, it's not gonna wiggle too much. Big head is gonna wiggle more, and as a consequence, the trunnion is gonna mash around inside the metal head and potentially create more metal debris. Other thing to understand is that corrosion occurs to a certain extent with every implant, with every metal, and it's just a fact of life. The question is when that corrosion becomes clinically significant. In this setting, let's go forward to your questions. if you don't mind.
Oh, yeah, sorry.
Yeah, no, you're good. So, to my way of thinking, the incidence probably has increased, but I think really what's changed is that we've recognized that it's happening
Mhm.
because of the debacle with metal on metal surfaces. With respect to what do you do about it, that's where I think the sleeves are appropriate in most cases if they're available. But that also means really knowing what's in there. And that's, as we've seen with Dr. Nelson's comment that, DePuy/J&J does not make an implant that you use.
28 plus 0.
Yeah, okay, so there's one.
Aluminum ceramic, not double.
Yes, stem removal, in some cases, with some implants, the only, if you have that bird beak or that, that little beaked implant, you really don't have a choice there. You cannot,
Mhm.
you can't do anything else other than take out the stem. With respect to managing local adverse tissue reaction, I mean, basically you got to get out all the dead stuff. And oftentimes there's not much left after you take out the dead stuff. The problem with changing implant design is that little changes make a big difference. And you don't always know that those changes are going to affect something until you've actually put them in. In general, when a manufacturer submits approval for a change in an implant design, it's essentially done through a 510K approval process, which is that this is a fundamentally equivalent to something that's already on the market. Ergo, they do not have to go through a complete approval process. Okay, where you have to, if it's a de novo device. A de novo device takes an astonishingly long time to get through the FDA approval process. It can take well over 10 years to get through the approval process, and most implant companies, frankly, are just not interested in doing that. Therefore, rather than doing the PMA approval process, which is the lengthy one, you essentially say, look, this is the same thing we've got. Yeah, we've been using this for 50 years. It's exactly the same. And so be careful when you're, as a surgeon, using a quote new and improved version of X.
Mhm.
It may be new, but it may not be improved.
Mhm.
I think maybe we're running pretty far behind. Maybe we have Dr. Crutcher, if you got a quick comment.
So recognizing this, the problem you identified, it could be as simple a fix as a head exchange or headline exchange. Question for the panel: recognizing the increased incidence of complications such as instability, infection, do you do anything different
Mhm.
other than just change the variants to prevent those complications?
So, you want to make sure the components are optimal position, right? So, if you try to just change one thing and things are not optimal, then it can keep your risk of those type of complications. And if you have abductor issues, depending on how much abductor damage, then you can enhance things of physical mobility or strength. And as I mentioned, I think for complete abductor loss, I think constraint is a little more effective in my experience, but.
Maybe I can round out the presentation, and Dr. Hernandez, if there's any other comments you'd like to make.
No, not really. Only thing I'll say is, I don't have years of experience, but STEM design, Matt, there's been a couple good studies that London group, London, Ontario has shown, like with certain stems using metal heads, they've seen no trunnionosis. And then some modern stem taper designs have seen a lot. So we know that head size, head length matters, but for whatever reason, I think the Zimmer Mercy stem, it kind of zoned out, just different, not to get into too many implant names, but it's worth, when you go into practice, learning the history on your stem, what the history of the Trunnionosis is somehow more than others.
I wouldn't say there's any stem or there's no trunk.
Right.
So, there's a study out of Germany out of the end of clinic. There they have the ideal situation, the treatable study, ideal situation for cobalt chrome stem, large 14-16 taper, 32 or 36 millimeter head. Not a super duper large head, and they see high levels of taper erosion when they look closer. So there's not, you're going to have taper erosion, period. It's a matter of whether or not it becomes clinically applicable. I agree that a larger taper, greater contact is going to lower it compared to a smaller taper, larger head. Smaller contact area, but it's a period.
Other than cost, is there any reason not to use a ceramic head on everyone? It's cost to get enough reason.
So I don't think there's a 36 millimeter ceramic head that's ever been reported that it's fractured on a native stem. So to me, if you're at 36, to me, there's really no reason not to use a ceramic head right now.
All right, I think there, just with time, we do need to move on. So I'm going to hand it back over to Zach to
Yeah.
wrap up the presentation.
Real quickly, just basic conclusion here. So our patient was seen back at the beginning of January. Again, he had had no dislocation since and using his abduction brace with counseling at that time about the complex risk and benefits of managing this. Being 97, having medical comorbidities, he elected for non-operative management. However, a month later, he had a dislocation event again, requiring a reduction in the operating room, and at that point elected for a revision. Prior to revision, it was discussed thoroughly with him that there could be need for femoral stem replacement, acetabular replacement, or any number of different modes of addressing the issue at hand. Ultimately, he was taken back to the operating room in late February. That time noted were metal stained fluids, metal stained soft tissues around the hip joint, including of the abductors, gross intraoperative trunnion corrosion on both the neck and the head, but no corrosion at the modular neck stem interface. Patient underwent debridement of the adverse local tissue reaction, revision to a ceramic head, a new modular neck with a titanium neck sleeve, and was stable throughout range of motion, but we still elected for a constrained aligner given the significant deficiency in posterolateral soft tissues. Here's the post-operative images here. Lasted 6 weeks. He was doing well. He was progressing in his ambulation and had no further dislocation events. Thanks a lot.
Great, thanks to everyone who presented this morning. These are all really complex topics that I think we all agree we could have several hour symposium on, so it's tough to cram it into 20 or 30 minutes. But we'll take a quick break now and then come back in around 5-10 minutes, and we'll pick it up with revision total knees to conclude this week's session. All right. I want to say thank you one more time to everybody, all the residents who've given great presentations so far this week. We're going to start our final set of resident-led discussions and case presentations now. We'll be concluding with the topic of revision total knee arthroplasty, and we'll be started off by Dr. Billy Crutcher, who's going to talk about total knee arthroplasty and instability.
Yeah. All right.
Thank you. Curtis has warned me, so I'm going to try and keep this moving. My name is Billy Crutcher. I'm one of the R5s here. I will talk about instability after total knee arthroplasty. So quickly, we'll review total knee instability, and then we'll do a case discussion. So instability is an important complication after total knee arthroplasty. It's one of the leading causes of revisions. It is a big and diverse topic that can't be adequately covered in this talk, but we'll go over some of the basics. Song it all nicely categorized the different causes of instability into 6 basic buckets. In their review of 83 revision total knees, 30% of the patients fell into more than 2 categories, so they can coexist and even compound each other. Pooja and Kurtis are going to be discussing extensor mechanism insufficiency and component loosening after me, so I'll focus on the others. Flexion extension mismatch is an important one that I'll talk about more on the next slide, and component malposition can be closely related to this. Oops. Isolated ligament insufficiency covers multiple distinct etiologies. One is PCL rupture after a cruciate retaining knee, which can present as a late cause of anterior posterior instability. Collateral ligament insufficiency causes varus or valgus instability after a total knee and can be iatrogenic with acute injury to the MCL, for example, or attenuation over time as a result of under or overcorrection of an angular deformity. Finally, there's global instability, which can be quite heterogeneous as well. This study describes 3 subsets of this: diffuse soft tissue attenuation due to things such as synovitis or recurrent hemarthrosis, then issues with the polyethylene insert, such as undersizing, fracture of the post or wear, and then frank dislocation. So this is a popular chart that we use when discussing sagittal plane balancing for a primary total knee. And these same principles apply here, but with the focus on these 2 boxes in the upper right for flexion instability. So flexion extension mismatch simply means the flexion gap does not equal the extension gap, which usually means it's loose in flexion when we're discussing instability. So this can be due to a few different things: undersizing the femoral component or not enough posterior offset, or inadequate distal femur section, which causes the extension gap to be tight and effectively leads to the loose flexion gap when that is balanced. You can also have excessive tibial slope, which disproportionately affects the flexion gap, or excessive posterior condylar resection, which only affects the flexion gap. So when the knee is in flexion, a loose flexion gap will result in distraction of the joint due to gravity, then activation of the extensor mechanism. We'll first have to pull the tibia into contact with the femur before generating enough force to rotate around into extension. So this is thought to be one of the mechanisms that causes pain and persistent recurrent effusion in patients with flexion instability. Mid-flexion instability is another distinct entity that is beyond the scope of this talk, but briefly, the flexion and extension gaps are balanced, that is at 0 degrees and 90 degrees, but between 30 and 60 degrees, there's laxity. This was first described in 1990 by Martin and Whiteside in a cadaver study where they raised the joint line and found mid-flexion instability. Clinically, the presentation is vague and the diagnosis can be difficult. Sometimes the laxity can be noted on exam through that mid motion, but sometimes the exam is normal. Patients often have difficulty with things like stairs and describe their knee giving way. Because of this challenging diagnosis, where the solution is a full revision total knee arthroplasty, these authors performed a systematic review to try and help identify some risk factors to aid in this diagnosis. They found inconclusive results with respect to joint line elevation and the radius of curvature, and postulated that articular surface conformity and the preoperative joint laxity play a bigger role than previously thought. So unstable total knees often fall into the bucket of painful or problematic total knee arthroplasties, which can be a challenging patient to work up. The differential diagnosis is broad and diagnosis is not always found. Some of these patients have intrinsic knee problems, while some are extrinsic. Some have knees that collapse or give way, even though the knee itself is stable. And then there's those with truly unstable knees. Infection should always be on the differential and be considering these patients, and labs and aspiration are often indicated. And these are just a few of the different algorithms out there and differentials described for working up a painful total knee arthroplasty, which encompasses more than just instability. So you must take a careful history, pay attention to things like the onset of symptoms, early presentation of unstable knees or knees that quote unquote never felt right are more likely to be a flexion extension mismatch or component malposition versus late instability, which is more likely to be soft tissue attenuation or loose components. And then things like, is the pain constant or activity related? What specific activities are troublesome? Going downstairs is particularly, trouble going downstairs is particularly common problem in flexion instability, whereas startup pain is more typical of aseptic loosening. Physical exam is extremely important in evaluation of these patients. You want to examine their gait. Do they have a varus or a valgus thrust when they walk? Is there an effusion present? Where do they have tenderness? What is the range of motion? Patients can paradoxically have stiffness in the setting of instability due to guarding, inability to rehab, recurrent effusions, etc. And then you want to carefully examine for coronal and sagittal plane laxity throughout an entire arc of motion. X-ray should be examined closely for things like component malposition, osteolysis, signs of loosening or fracture. In the setting of osteolysis or bone loss, CT scan can be used for further preoperative planning, and bone scans sometimes used to evaluate for aseptic loosening. So that brings us to management, which we discussed is largely dependent on which of these specific entities or combined instability we're dealing with. This can be as simple as non-operative management in patients with mild instability, or isolated polyethylene exchange is sometimes indicated, but should be carefully selected as it's been shown to have high rates of failure when used for instability. This is a 2002 study of 56 patients in JBJS that were treated for either wear or instability with an isolated polyethylene exchange, and 25% of them had a revision before 3 years. And then the final option is a revision total knee arthroplasty. So when discussing revision in primary total knee arthroplasty, constraint is an important concept to understand, and hopefully is a little bit of a review for some of the junior residents. So this refers to the amount of motion allowed at the articulation. So if you think about a total shoulder versus a total hip arthroplasty, there's much more constraint in the total hip, whereas a total shoulder allows for translation between the components. So in the knee, we're talking about the motion between the polyethylene insert and the femoral component. So the least constrained design is the cruciate retaining knee. This is the polyethylene on the top here, where there's no post. The PCL is preserved, and there's no post on the polyethylene. Then there's the posterior stabilized knee, which is what we're most familiar with training here at UW, with the tibial post that articulates with a cam in the femoral component, but doesn't completely fill the cam and allows for some toggle and motion. Next are the more congruent polyethylenes like the CCK or the ultra congruent polyethylene, which also have a post, but it's wider, filling more of the cam and allowing less motion between the components. Finally, there are linked or hinged prostheses where the femoral component and the polyethylene are actually linked with a bolt. And these are typically reserved for global instability or severe flexion instability. So as you increase the constraint and decrease the motion between the components, you transmit more force to the bone cement interface, which can lead to component loosening. So typically, as you increase constraint, you want to increase the surface area of the bone cement interface and distribute these forces, usually in the form of a stem, which engages the metaphysis or the diaphysis. So in modern day hinge prostheses usually have a rotating platform, a tibial platform, which is another way to help dissipate those forces. So moving on to our case, a 59-year-old male with a complex surgical history with respect to his left knee. First, he had a traumatic injury at age 18 with numerous subsequent operations. He can't really give you great details on, followed by an index total knee arthroplasty at the age of 30, followed by 2 revisions, one at age 33 and one at age 40. So he's now 59. These are his x-rays from 2004 at the time of his last revision, and this did well for him for a number of years. We don't have all the info, but it wasn't a very involved revision with stems or augments. It may have just been a polyethylene exchange, he's not sure. But it appears to be an uncemented primary total knee with metal back patella. And he comes into your office with these x-rays. I'll come back to those. Of note, he has a complex past medical history, then with numerous coronary interventions, chronic kidney disease, diabetes. He's recently status post a bariatric surgery, which was complicated by new weakness in his left lower extremity, concerning for possible stroke, but undiagnosed. And that kind of precipitated this new problem with his left knee. He also has a history of depression, former heavy smoker. And now he's ambulating with a walker. Previously, he was not, and his knee has been giving out, and he has pain, which is his biggest complaint, and it's mostly medial. So on exam, he has limited range of motion, 5 to 85. He has medial joint line tenderness, 3 out of 5 strength and knee extension, but his knee is stable to varus stress, anterior posterior stress. He also has this non-tender mass in the distal lateral thigh. So back to his x-rays, you can see there's on the lateral, there's irregular radiolucencies in the metaphysis, as well as the larger, more discrete area of erosion, this lateral femoral condyle, distal femur metaphysis, which is concerning for possible malignancy. I forgot to mention he has monoclonal gammopathy. However, his components appear well fixed. So he underwent an oncologic workup and infectious workup. Those were negative. So it's thought that this was mostly due to osteolysis in the setting of polyethylene wear. And ultimately, he was cleared by the pre-op medicine team to undergo a revision total knee for his persistent pain and dysfunction. So he underwent this revision total knee arthroplasty, where stemmed revision total knee components were used, as well as a constrained polyethylene insert. Following surgery, he was doing fairly well, recovering as expected, ambulating with a walker. Till one day around 5 or 6 weeks post-op, he just felt a pop in his knee while walking. And this caused a setback in terms of his range of motion and his mobility. And at 6 weeks, he was seen in clinic. He was more stiff, but it was significantly guarding, so difficult to assess for any laxity. But he was noted to have this displaced lateral femoral condyle fracture. There's no subsidence or loosening of the components. He was prescribed a hinge knee brace at this time, but before he could get it, the next day he presented to an outside hospital ER with a dislocation of his knee. Fortunately, there was no neurovascular injury, and he underwent general anesthesia, had this close reduced. Came back to clinic a few days later with these x-rays, reduced but significantly painful and guarding. So at this point, I'd like to open up to the panel, ask what your thoughts are on this case, what your next steps in management would be, and then maybe more generally, if you could talk to us about your approach in the clinical evaluation of an unstable total knee arthroplasty, and if you have a standard approach, what is your order of operations when revising for instability?
So that's a lot.
Yeah.
I think you're going to try to fix the stability. So as a general rule, most times if you have, first of all, in a case like this, you want to make sure that his instability is not motor related if he had a stroke, right? So you want to make sure that his quads are, it's in 3 out of 5 strength. So it sounds like you may have some neurologic issues that you can't fix with the surgery. So you have to recognize that and not try to fix that. So things that are extrinsic to the knee, you can't fix by fixing the knee. But once you rule that out, usually most cases, if you have coronal instability on one side, you can usually fix that with a varus-valgus constraint device that is appropriately tension and appropriately sized with appropriate flexion gap and addressing the tight flexion gap. If it is sagittal instability, meaning it hyperextends, or it's a ridiculously large jump that can jump the post of a varus-valgus constraint, then you need a hinge device. That's the general algorithm. And it's really restoring joint line, position, size, and mechanically making the device appropriate. This case, because of that lateral condyle issue, because of the significant lysis in that area that fortunately, malignancy was ruled out, you may want to be prophylactic as far as either considering a hinge device to protect it at the time of the revision, or having a cone where you can try to fix. Where you can try and fix the condyle to the cone. Now, there aren't any cone devices that are available right now that allow that, at least unless you're getting creative and kind of drilling into it yourself. But there is a patent on that hopefully will get licensed at some point. As far as at this stage, this is I probably would initially try and treat this non-operatively, and hope that provides if need be, you might even, with this gentleman, if you can't trust them from a bracing standpoint, you might even put the cast just to try and get it to heal and resolve that issue. So that's probably what I would do at this stage.
Yeah, that was what was attempted, as you'll see unsuccessfully. That was I think certainly my initial approach. One dislocation is a bad harbinger for sure things to come, but I think attempted management knee brace, protect the weight bearing, particularly for a very unhealthy person revision within a short amount of time. Medical risks and surgical risks of infection certainly escalates.
Yeah, so that's exactly what was done. He went into a hinge knee brace. Fortunately, had 2 more dislocation events that were reduced while wearing the brace, and ultimately underwent this further revision to a distal femoral placement with hinge prosthesis.
Why distal femur instead of normal pinch?
Yeah, so the lateral condyle was obviously fractured as noted. The plan A was a resurfacing hinge. I mean, the entirety, I think, by recollection, at least, the lateral condyle was absent. You might have even prepared for a rotating hinge, but I know you showed an image where the resurfacing hinge was, exclusively supported by the medial condyle. I think it just gave me some apprehension, I suppose, particularly for an unhealthy person. I mean, this has a high risk potentially of failing as well, but I think for a resurfacing hinge supported by one condyle.
Well, the only thing I would say is that the advantage of, because you can get it combed into the diaphysis and extending into the metaphysis. And that gives you rotational stability. And you can use a stem that's just as long as that stem, that goes just as far up. So it's going to give you the exact same fixation further up, and it's going to give you enhanced rotational stability distally. So
Yeah,
to me, I try not to throw away good bone.
Yeah, and he's young, as well,
Yeah.
so I think
And then
the plan was.
the other is if
to
this
keep
fails, then you're AK, right? You got 0 chance of.
I think I discussed AK at the index surgery. I wasn't really sure how much lysis I'd expect, how much destruction would be present. And I think he has pretty extensive lysis, including even medium condyle. So regardless, yeah, I agree. The least constraint you can use, the better, particularly for younger people. It's fairly low demand, but hopefully this is more definitive.
Certainly was easy to get the femoral components out.
Without a doubt, yeah.
Nothing to do.
Now, what about his patella? I mean, it's a tough problem because there's not going to be any bone left when you address that, but it looks like maybe that was generating some of the debris that was causing his problem.
Yeah, so another thought as to why he had that degree of bone loss was some type of metal on metal articulation. It's colochromium level normal, to my recollection. We did an MRI which showed, well, fluid collection, not necessarily pseudo tumor, and it was mostly serous. It's pretty impressive. Rotated through his condyle. I don't think I had seen that before, so I think I talked to tumor colleagues about how to evaluate that. But this is an old acute, I think.
LCS, it's an LCS. So
We didn't have to call me for the patella, and I removed it so I wouldn't injure it at the time of the revision, and I put it right back on.
put the same polygraph.
Yeah, they couldn't get me.
They could get it for you?
Need to find a new computer.
Yeah. You have a lot of problems with you, man.
Or it would have taken like several months or something.
Yeah, I mean, they may not, because they probably don't make it anymore. It's probably old, it's probably aged beyond the point that you probably, it's
It didn't have any
not good.
severe wear, so.
Well, thank you for the discussion. To conclude the case, he's now about 4 months post-op. He's doing better, improved motion, decreased pain, and ambulating with a walker. So we'll see.
Wow.
Thank you. Yeah.
I'm curious, I've seen people, at least, when I was in my fellowship, kind of more people maybe trying to, I tried, a similar situation like him and Hine, distal femoral replacement. Now that there's cones, maybe we should try to get a sleeve or cone in there and do some reconstruction. I mean, have you had success with that, or are you aware of good studies to show that it's the way to go now type thing? Because I've seen people kind of debate that kind of situation for a while, and not to use, the Anderson classification of here, so like a free, no good femur,
Well,
just shell of condyle.
I think part of the challenge of having, so there's plenty of studies that demonstrate really, out of Mayo, really good results using cones. but they don't really stratify for the severity of bone loss. And again, I don't think there's a really good classification system for these that does that, that is really quantitative. You know, because you could say those are, you know, Anderson F2 or T2, AB, whatever, but there's a whole spectrum, you know, so it's a, so I think that's one of the reasons we need a better classification system that allows us to accurately compare similar situations. But I can't think of one of those cases where we've done that type of a cone reconstruction for that type of couple cases I've shown today where it fails. You know, where I've seen a lot of distal femurs or, you know, distal femoral replacements fail. You know, even when you go, I mean, those things don't do well a lot of times, you know. So I'm not a big fan of that approach. I try to avoid it whenever I can. Sometimes it's the only option, you know, so it's a good salvage option, but I try and save the bone I can save. And again, I think that axial bending and rotational stability it just makes common sense that those things are important principles. And it makes common sense that if you have a stem and the only thing that's controlling rotation is the little flutes in the stem, that's not going to really effectively control rotation long term. So.
Well, I think that's a great transition into the topic that I'll be presenting on today, which is aseptic loosening with bone loss in the setting of revision knee arthroplasty. I have the difficult task of following up Dr. Nelson's talk on a very similar topic. But what I hope I can do is shine some light, especially for the residents, onto the options that we have available to manage varying degrees of bone loss in the revision knee setting. So depending on the source that you look at, aseptic loosening represents either the number 1 or number 2 most common cause of revision for knee arthroplasty patients. It's either that or infection. As we've developed longer lasting polyethylenes, revision for polyethylene wear has become less and less common. We've already touched on the Anderson classification system for bone defects, but to briefly recap it, it stratifies patients into one of 3 groups, with patients with a type 1 defect being those who have minor and contained cancellous defects that do not have any effect on underlying implant stability, while patients with a type 2 defect are those with moderate to severe cancellous or cortical bone defects that further stratifies into 2A and 2B based on if only the medial or lateral or both sides are affected of either the femur or the tibia. And then lastly, patients with a type 3 defect are those with massive cavitary defects or segmental bone loss, often necessitating complex strategies for reconstruction. So before we actually get into the techniques that we use to tackle bone loss itself, I think it's important to discuss the use of modular stems in revision knee arthroplasty. Modular stems are used to bypass deficient or damaged regions of bone, thereby enhancing the stability of our revision construct and diminishing strain at the implant host bone interface. There's a multitude of literature out there examining stems on both the femoral and tibial side. This study by Dr. Nelson's group out of UPenn examined 130 revision total knees with at least 2 years of postoperative follow-up, and they found a 5-fold greater rate of failure in those patients who were treated without femoral stems. Similar results have been found on the tibial side. This certainly isn't the most powerful study, but it's a 2015 study published in Core that looked at 58 revision total knee patients treated with short cemented tibial stems for a variety of bone defects up to grade 3 with a mean of 5 years of follow-up, and found no revisions for tibial component loosening in that group. So multiple authors have concluded that in the vast majority of revision knee, if not all revision knee patients, routine use of stems is likely advisable. So after establishing that, how are we going to move on to actually tackling bone loss itself? For patients with relatively small bony defects, the most conservative measures that we can think about taking is either isolated cement or the use of cement with supplemental rebar screws. So cement alone is typically reserved for relatively small bone defects that are less than 5 millimeters in depth and comprise less than half of the bone surface that will be articulating with the implant itself. For somewhat larger defects, we can augment our cement reconstruction with rebar screws, as is shown in these surgical photographs and radiographs on the right. This is a well-established technique. This, for example, is one landmark study in JOA back in 1993 that found 0 failures and a mean of 6 years of follow-up in patients treated with rebar screws. So well-established, has been used for quite some time. As we move up our reconstructive ladder and get into somewhat larger defects or defects that may require a little bit more intensive planning, we get into impaction allografting. Patch allografting, I'd say, has been more described for its use in revision hip arthroplasty, but certainly does have some indications in the revision knee population. It's typically used for smaller, more contained defects, but when used along with a wire mesh to control the graft itself, it can also be used for uncontained defects as shown in these radiographs here. This is another well-established technique. This 2011 study published in Core found a 98% rate of prosthesis survival at 10 years in patients treated with impacted morselized allograft. Once we start moving on to our larger bony defects, specifically type 2B and type 3 defects, we start getting into cases where we're going to need either bulk structural allograft or supplemental metal prosthesis augments of some form. Beginning with the bulk structural allografts, we have different varieties of bulk allograft that we can use. Illustrated here in these images on the right is the most common form of bulk allograft, which is bulk femoral head. One of the methods that this can be utilized is shown here, where the defect is prepared with an acetabular reamer, and then a further prepared femoral head allograft can be placed into the defect and secured with screws. There also have been described cases of bulk distal femur and proximal tibia allograft being used as well. The literature out there on bulk allograft hasn't been as clear as it has been for some of our other strategies for bone loss. To illustrate that, first, this 2009 study published in Core looked at 70 revision knees treated with a variety of different forms of bulk allograft, both femoral head, distal femur, and proximal tibia bulk grafts. And they found over 22% rate of revision in that population, half of which was due to failure of the allograft itself. So these authors concluded that they were not happy with the success rate that they were seeing with bulk allograft and advised against its routine use. This is in contrast to a more recent 2017 study published in Core that did look at a relatively small cohort of 45 revision total knees, 2/3 of which were treated with femoral head allograft, 1/3 of which was treated with cones. And they found a comparable rate of 5-year survivorship between the allografts and the cones. These authors suggesting, in contrast to the prior study, that maybe in fact bulk allograft is a viable option in these patients. Next, moving on to the prosthetic options and away from the allografts, we get into what I'd say is likely the most common type of augment that we see used in a wide variety of different forms of revision knee arthroplasty, and that's the use of modular wedge and block augments. So these are useful for both contained and uncontained defects, classically described as being used in defects that involve over 40% of the bone implant interface, or in those involving greater than 1/4 of the adjacent cortical bone. There's a variety of different kinds of these augments available for both the medial and lateral tibia, distal femur, and posterior femur, providing the operating surgeon with a multitude of options available to address the specific defect for each patient's case. Once again, these are very well established in the literature. For example, this 2004 study in the British edition of JBJS found a 92% implant survival rate with these implants at 10 years. As we get into strategies to tackle larger bone defects and metaphyseal defects specifically, we get into the porous metaphyseal cones and sleeves. Once again, these are most useful in type 2 and type 3 defects and function by providing a stable metaphyseal platform for osseointegration that increases the contact area between the underlying metaphyseal bone and our implant. Both cones and sleeves represent viable options. In these right-sided images here, we see a surgical photograph of a cone and as well as the corresponding radiograph for that cone, which demonstrates that it does provide some support of the lateral metaphysis, but primarily serves to replace a deficient medial proximal tibial metaphysis in this case. And then on this right-sided radiograph, we see sleeves for both the femoral and tibial component. Once again, there's a multitude of literature supporting the use of these implants, both cones and sleeves. This 2021 study out of HSS, for example, examined 163 revision total knees that utilized tibial cones and found a 96% survivorship from any non-modular revision at a minimum of 2-year follow-up. With respect to comparison of cones to sleeves specifically, there's been several studies that have compared the two directly and have yet to show a significant difference between the two. For example, this 2022 study out of the Rothman Institute compared a high number of both femoral and tibial cones and sleeves and found no difference in the rate of aseptic failure between those at 5 years postoperatively. I won't delve too much into this, but lastly, in patients with non-reconstructible defects, we do also have megaprostheses available to us. So next, I want to move on to talk about our case presentation because I think that this will prompt a very good discussion. In this case, our patient's a 59-year-old woman. She's otherwise healthy, and she originally underwent a left total knee arthroplasty in 1998 at the age of 43. We don't know why, but she subsequently underwent 2 revision total knees, the most recent of which was in 2006. After that most recent revision, she states that she was very happy, was able to ambulate independently, and was very pleased with her function. So it's now 9 years after her most recent revision total knee, and she comes into our clinic saying that she's having 6 months of steadily worsening left knee pain. She now needs a walker for any ambulation. On her exam, she has a BMI of 40. She has limited knee range of motion with 4 out of 5 knee extension, but her knee is stable to ligamentous stress. But notably, she does have a significant leg length discrepancy, with the left side being 3 centimeters shorter than the right. So we get these radiographs, and this is what we're greeted with. So to quickly go over these, we see a cemented a distal femoral replacement, as well as a cemented sleeved revision tibial component. Beginning with the femoral side, the cement mantle looks intact, no evidence of kind of gross loosening on the femoral side. But on the tibial side, we see substantial bone loss, major subsidence of the tibial component. Here we have some AP and lateral radiographs to view the entirety of both the femoral and tibial side. An infectious workup was undertaken, which was reassuring. The patient is adamant that she wants to keep her leg and wants to try to get back to a functional level. So I'll now pose these questions to the panel. I think it's something we can kind of just talk through your approach to this case to start off.
Well, you already know the distal femur is missing as far as how much bone loss is present. So, I mean, this device does allow you to revise the device and, put another device. I personally, I'm a bigger fan of cones than sleeves personally, but I agree that the results are very good with both, when you have biologic ingrowth. I think the challenge here is you have a very, very thin tibial cortical shell that's remaining, and this is to me a pretty good indication for the Mayo technique of a forced metal cone combined with impaction grafting, and trying to bring that joint's surface back up where it belongs. You can see, this looks like it's below. It's at the level of maybe the bottom of the tibial cervical if you look at the lateral. So I would try to enhance that and use a cone in there to try to create some biologic fixation. You don't have a whole lot of bone to work with, but that's the way I would address this. And then I would impaction graft and then put a fairly long cemented stem into that impaction grafting and hope that it models and heals, provides some stability. So the cone should be able to give you some initial stability. Impaction grafting should help reconstitute bone and allow you to get some interdigitation and then add very, very thin residual shell. But it's again, these rotating hinges, particularly with distal femoral placements, there's a lot of stress on them. And that femur, you got enough work to do with that tibia that I wouldn't revise it right now. It's not going to shock me if you do a great job revising that tibia, that femur ends up failing in the not too distant future.
I think like long leg.
What's that?
It's that you're clairvoyant.
I think like long leg alignment film could be useful in this. Like obviously it looks like she's really subsided.
Yeah.
I expect that's probably, there's no subsidence on the femoral side as well, but we didn't see the top of that component. And it looks like she actually was standing quite straight upright on those films, so just centered at the knee. But to give you an idea of whether to expect that femoral component to just fall out as well, which I'm sure.
So I think you brought up an interesting point, Dr. Nelson. If only the femoral of the tibial component is loose, what's kind of your threshold to revise the other?
So for most cases, it's rare, very rare that I will do a tibial component divisional. This is a case where I probably would. Because in this case, you're gonna have no issues. You can take off that modular femoral part, you can have great exposure. And it's a very simple case. Other than all the bone loss and everything, but in most cases, if you're doing a tibial only revision, if you have a primary knee implant that cannot accept the varicose constrained implant, by the time you get it exposed enough to be able to put a stemmed implant down your tibia without taking off the femur, even if it was stable beforehand, there's a good chance that when you finally put that final implant in, it's not going to be stable. So to me, there's a very, if you got a device that can accept a stabilized implant, I think you can do that. Properly rotated, properly positioned, etc. The other thing is most times when there's a failed knee, because they're so interrelated, there's more than one problem. So to me, simple component revisions for knees are much less appropriate than they are for hips. They are occasionally appropriate, but tibial only is extremely rare, unless you got a device that can accept some strain.
And I think for exposure alone, in this case, as Dr. Nelson said, you can take off the distal femoral component, but for most, it's my experience, knee revision, once you remove the femur first, I think you're compromising the exposure and maybe generate another problem.
You can get the exposure, and it's, sometimes you go through the trouble of getting the exposure. Get everything in, you get the device, you get the trial in, but you need even a little bit more exposure to put in the longer stem cement, and now it's unstable, and now you've kind of locked. Then you've done all that work, and now you got to revise the femur anyway, so it's to me, there's very little goal for that.
And then one question that I had actually during your talk, and I wanted to wait till now to bring it up. With the advent of cones and sleeves and their use becoming more popular, are you still using a lot of bulk allograft, or has that kind of fallen out of favor in your practice?
It's fallen out of favor. I think, unless you're in Canada, results of bulk allograft aren't that good. I mean, they're Allen Gross, they're good. Cooper Group, maybe, Canadian bulk bank is better than our bulk bank, but so I don't use them much, but I'm not going to say I never use them. And when you have a unicondylar defect, one downside of cones is you're sacrificing bone if you've got pristine bone on the other side in order to get the cone in. We don't really have unilateral cones that are developed. You could take like an acetabular augment and use it as a unilateral cone, but there's not anything that goes developed. So very rarely, but it's something you can't use. You can cheat it, which is nice.
Right. So we've had some preview of where this case is headed, but this patient went to the operating room. As already discussed, the distal femoral replacement was removed. The stem was felt to be stable, so the decision was made not to revise the femoral side. On the tibial side, the series of 3 stacked tibial cones, as well as a long cemented stem was utilized. This construct actually served the patient very well for 6 years. But 6.5 years post-operatively, she came back with acute left knee pain after feeling a pop, and as had been alluded to, patients had catastrophic failure of her distal femoral replacement. She then underwent a revision distal femoral replacement, after which, once again, she was able to get back to independent ambulation without an assistive device. But then in a fall, 4 months post-operatively, and had a fracture at the tip of that stem. She underwent an attempt at ORIF with a lateral plate as well as a femoral strut allograft, which unfortunately did pull out. Ultimately, she went on to a total femoral replacement. She's now coming up on 8 months post-operatively, and at her last follow-up is doing quite well with this. But I want to draw your attention to that stacked tibial cone construct down in the tibia is still going strong.
All right, hello everyone. My name is Pooja Prabhaka. I'm a new resident, and I will be finishing up our talks for today with a discussion on sensor mechanism disruption after total knee arthroplasty. So a brief outline of my talk. I'll start with giving some background on extensor mechanism disruptions as well as risk factors for this injury, and then we'll discuss management options. And then I'll go over a few studies on outcomes for the reconstruction options, and then we'll move on to the case. So sensory mechanism disruption is an uncommon but serious complication after total knee arthroplasty. It's associated with significant morbidity and reduced quality of life due to extensor lag, instability, difficulty walking, recurrent falls, and pain. And disruption to the extensor mechanism can occur at 3 places. You have a rupture at the quadriceps tendon, fracture of the patella, or rupture or avulsion at the patellar tendon. The overall incidence is between 0.1 to 2.5% and further broken down by location as shown. The 2 general mechanisms of injury are traumatic and iatrogenic injuries. Traumatic injuries can occur from a fall, and iatrogenic injuries can occur intraoperatively, such as direct injury to the patellar or quad tendon, or rupture due to difficult exposure of a stiff knee or a knee with patella baja. There's also some iatrogenic factors that may increase risk of injury postoperatively, either in the early or late postoperative period. So you can have lateral retinacular releases that can cause a vascular insult to the superior lateral genicular artery, which can increase your risk for patellar fracture. Similarly, if you have an aggressive patellar resection, you also increase your risk of patellar fracture and or compromise the quad tendon insertion. Also, knee instability or malposition of the components, such as excessive elevation of the joint line, or internal rotation of femoral or tibial components, or lateralization of patellar component can also increase your risk. And in these cases, the components may need to be revised at the time of the extensor mechanism repair reconstruction. And several case series have reported the need for simultaneous component revision in these patients as high as 78 to 83%. Some other risk factors would be multiply operated knees. Some studies have reported that patients with a disruption have undergone, on average, 3 to 4 previous knee surgeries. And also systemic conditions like renal disease, diabetes, rheumatoid arthritis, and obesity can increase the risk. So when you're evaluating a patient with extensor mechanism disruption, it's usually a clinical diagnosis if the patient has lack of full active extension. Additionally, they could have instability, difficulty with stairs, anterior knee pain, and you may be able to palpate a defect. It's also important to assess for factors that could have contributed to the disruption. So instability, patellar maltracking, making the need for the component revision more apparent. And you also always want to check for infection. You don't want to put a graft into an infected knee. And looking at radiographs, you can make a diagnosis there's a patella fracture, or if you see patella baja or alta. And you can also, at the same time, assess for the component alignment. So the treatment options are non-operative and operative. So non-operative treatment indications for extensor mechanism disruptions are generally for patients with less than 20 degrees of extensor lag, partial ruptures, and non-displaced patella fractures with intact extensor mechanism. And these patients can be placed in a extension cast or splint for 6 weeks. And conservative treatment may also be acceptable in elderly low demand patients who can use knee braces or walking aids. Operative treatment options include repair versus reconstruction. So indications for repair are acute patellar tendon ruptures with adequate bone stock or acute complete quadriceps ruptures. However, there are high re-rupture rates reported with direct repairs. So reconstruction has been the mainstay of surgical treatment for chronic obstructions of the quad tendon, patella, and patellar tendon. And there's several options for reconstruction, which I'll give an overview of. The final surgical option is arthrodesis, which can be indicated in patients with a disruption in the setting of infection. And I do just want to mention briefly the classification for periprosthetic patellar fractures, which is the Ortiguera and Berry classification. So type 1 is a stable implant with intact extensor mechanism, which we discuss is treated non-operatively. Type 2 fractures with disrupted extensor mechanism, so they would undergo repair or reconstruction. And a type 3 fracture could be treated with patelloplasty, with revision, or patellectomy, depending on the availability of the bone stock. So back to the reconstruction options. These include allograft, autografts such as semitendinosis, synthetic Marlex mesh, and local flaps such as a gastroc rotational flap. So I'll just focus on allograft and synthetic mesh. And the two most common options for allograft reconstruction are Achilles allograft with a calcaneal bone block and a whole extensor mechanism allograft, shown in the photo here. So Achilles tendon allograft with calcaneal bone blocks indicated for chronic quad or patellar tendon ruptures. And its increased length is especially useful for quad ruptures where there's significant proximal retraction. And whole extensor mechanism allograft includes proximal tibia, patellar tendon, patella, and several centimeters of the quadriceps tendon. And this is indicated when there's deficient patella or poor quality of extensor mechanism tissue. And it can also be used for any and all extensor mechanism disruptions. And just a few studies on the full allograft. So tensioning of the allograft is an important aspect of surgical technique. The study in JBJS in 2005 compared 2 tensioning techniques in a series of 20 patients who underwent full extensor mechanism allograft reconstruction. So the first group was the first 7. They had their allografts minimally tensioned, and second group had them tensioned in full extension. And all the reconstructions in group 1 were clinical failures, with the average post-op extensor lag being 59 degrees, while the group 2 extensor lag was only 4.3 degrees. And this is a case series out of Brush that was published in 2015 in JBJS that assessed 50 full extensor mechanism allograft reconstructions, tension and full extension. And they defined failure as post-op extensor lag over 30, any society scored below 60, or that they required a revision surgery. And 38% of these reconstructions were failures. 4 of them were revised due to allograft failure, 5 infections, and 10 just because of the extensor lag or knee society score. But the mean knee society score improved from 33.9 to 75.9. For Marlock's mesh, this is a monofilament polypropylene mesh that's been used by general surgeons in hernia repair. And in the last decade, it's been utilized in extensor mechanism reconstruction. So it's rolled onto itself about 8 to 10 times into a tube and then sewn over. And it can be fixed into the tibial tubercle either via a trough or cemented into the canal if the tibial component is being revised. And then it's sewn into the quad tendon sandwiched between the vastus lateralis and medialis. And it's thought to have some benefits over allografts, such as reduced risk of disease transmission, lower cost, near universal availability, and diminished graft stretch out. So this study is the largest series that was published of patients with extensor mechanism disruptions after a totally arthroplasty treated with Marlock's mesh, and is published by these authors out of the Mayo Clinic in 2008 to JBJS. And there's 77 patients with a mean follow-up of 4 years. And 23% of the patients underwent reconstruction for a primary TKA, while the rest underwent a during revision TKA. And of note, 26% of them had a prior attempt of reconstruction. And at final follow-up, 84% of the mesh reconstructions were in place. There were 12 failures due to patellar quad tendon ruptures or symptomatic lengthening, but the mean extensor lag improvement was 26 degrees and the mean post-op extensor lag was 9 degrees. This is a retrospective cohort study that was published this year that was comparing allograft and synthetic mesh reconstruction with an average follow-up of 3.5 years. So they had 20 patients who underwent allograft reconstruction and 35 patients who underwent mesh reconstruction. And the only significant difference between the groups was postoperative flexion, with allograft having just a few more degrees, but there was no difference in their outcome score, extensor lag, graft failure, revision surgery rates, surgical time, or ambulatory status at their most recent follow-up. And the most common complications after repair or reconstruction of the extensor mechanism, as reported in a recent systematic review in the Journal of Arthroplasty, was extension lag of 30 degrees or greater, which is 45%. And the rate of re-rupture and infection were also similar, around 25%, and contraction was less common at 3%. So we'll move on to our case. So this is a 61-year-old female who underwent a right total knee arthroplasty in 2012 in Tacoma. Her case was complicated by patellar fracture a year later, and she underwent fragment excision at an outside hospital. We don't have images at that time, but the most or the earliest X-rays in our system are from 2015, which is after the patellar fragment excision. So there's some radiolucency through the lateral patella on the merchant view and the axial CT cut, but the components appear well fixed, well aligned. She did well following the excision, but then was found to have a partial rupture of her quadriceps tendon, and she underwent direct repair in 2016 at an outside hospital. She then presented to our clinic in October 2017 with persistent pain and instability. She was confined to a wheelchair, and she noted that she had pain around the kneecap, worse with weight bearing. And for her H&P, depression, hypertension, social history, she's a former smoker. At the time when she was at our clinic, she denied alcohol or drug use, but a later ID note a few years later noted meth use. So her physical exam at the time, her BMI was 29, she was in a wheelchair. Her right knee exam, she had a palpable partial defect of the quadriceps tendon. She had a 30-degree extensor lag, 100 degrees of flexion. She was non-tender at the joint lines, positive patellar grind test. Her patella was tracking centrally. She had 4 to 5 quad strength and stable with varus valgus, but had mild instability with anterior and posterior stress testing at 30 degrees of flexion. And she did undergo aspiration of her knee that was reassuring against infection. So these are her standing radiographs from that initial clinic visit, which demonstrates patella baja. So just some questions for the panel. For this case, what are her treatment options and what are your thoughts on allograft versus mesh? And I also just wondering what your indications are for non-operative management and what your patient experience has been with bracing. And if you just have any pearls for us as residents of your intraoperative techniques on preventing patellar fractures, quad tendon ruptures, patellar tendon ruptures. And then also, what do you consider revising components at the time of extensor mechanism reconstruction?
So other than recalcitrant infection, this is the worst complication you have out of knee replacement surgery. And there is no good option. And if you look at the Mayo series, the outcomes will be worse with longer follow. Every single series, when they first present it, they don't have as much lag as they get older. Things stretch out, and I don't, the slide that said that the allograft stretches out more than the mesh. No, I think the allograft has longer follow-up than the mesh. And I think that last study really looked at that where they saw really no difference. So I think all of these techniques, none of them are optimal, and I think we need a better technique. Now, there are some people who have reported some improvements if you try and get some biology in there, let's say a gastric flap, and to bring some biology in there, maybe that helps to improve the outcomes. And maybe we need a combination of something that's mechanical, like either allograft or mesh, combined with something that's biologic in order to address these problems better. But we don't have good answers for this, and I think the biggest challenge is getting the quad tendon that has already been disrupted and has lost some of its malleability, but getting it to heal to the mesh or the allograft in a way that it doesn't stretch out over time. And I don't think it's a question to answer now, but some of these techniques, people at least improve to the degree that they can function without their leg giving way, without using the brace in some cases. But this is a challenging problem, and in this case, just because of cost, I would use mesh instead of allograft because the person's got a good patella, and I don't think either technique is great. I think the one thing that's nicer about allograft is it's easier to get it aligned in the right axis. If you put the tubercle where the tubercle was, your tendon is there, your patella is there. So I think the alignment's a little bit better than kind of running the mesh around the lateral side of the patella and then onto the vastus and then taking the medialis and overlapping it, which is less anatomic, but I don't think there's a great technique. I think we need a better technique that has both mechanics and some biology.
Yeah, I personally, I think you need to think about this in like an algorithm too. Is this acute or chronic, and where is the extensor mechanism disruption as well, which is important. So when it fails on the patella, it's usually more distal, but if it fails acutely, at least at the inferior pole of the patella, I think I've at least done a couple like direct repairs, but augmented with allograft reconstruction with hamstrings, which seems like it's at least a potential salvage option. And then if it fails later, you still have mesh or allograft. Again, no good options there, but it's an option to be able to proceed with. You're not posing yourself for future salvage essentially. But for the chronic ones, I prefer mesh as well. I get a little worried about using allograft, but they make it sound simple as far as the idea of doing it by maintaining the components, where you make a trough, but it's a lot technically more challenging than that sounds, to be able to hold that in place with the cement, put a screw through. It's technically challenging procedure to use mesh for the extensor mechanism reconstruction, and you have to make sure that the mesh is fully covered as well with soft tissue, and you're not just closing skin directly over mesh. Then you're creating another problem. But both have potential for infection. But I worry a little more about allograft than mesh. But again, this is my experience as a more junior member of the panel here.
Yeah, I think to that point, people sometimes conflate transverse tear or tendon versus a heel or a avulsion, which can happen in exposure and revision cases in particular. So thankfully, those are hopefully prevented. Prevention's the key to all of these techniques, but we can use suture anchor, crack out techniques. If it's an avulsion, I think a tear along the body of either of those tendons very, very difficult to repair in a satisfying way, and usually requires an extensive period of protection. That could certainly compromise motion, but it's a bigger poison, I suppose. I don't think I was involved in this case. I don't think I knew that she had that history of Matthews.
Yeah, I didn't know before. It was after.
Mesh also think that probably might have a slower risk of disease transition or risk of infection.
Okay, so to conclude the case, she underwent reconstruction 7 months later with an allograft full extensor mechanism. The residual patella was removed and the allograft was prepared with attached tibial bone block, which was then fixed to the patient's tibia with cerclage wires. And the femoral and tibial components were, they appeared intact and they were in a perfect position. She was placed into a long leg splint. These are post-op radiographs. And she was seen for 2-week and 6-week post-op visits. She was also followed up for about 1 year and 3 months. That she called stating that her leg was infected. And she was at an outside hospital where they had done an IND of her right knee. And she was found to have group E strep, PJI. She had continuous systemic signs of infection, afebrile. She was transferred over to our hospital. This was the initial X-rays when she came in. This is they have staples, and she had just done the IND, and then she underwent IND here with poly exchange, removal of cerclage wires, and retainment of the femoral and tibial implants. And at the time of the surgery, the allograft was expected and noted to be intact, and she left AMA, but she's prescribed amoxicillin. And these are post-op X-rays which show the antibiotic feed placement. And she didn't follow up with ortho, but she followed up an ID clinic, and she didn't want to undergo remote components, and she wasn't able to have an IV antibiotics due to her social situation. So the plans for chronic suppression, amoxicillin. She ended up coming back to the orthopedic clinic once. At that time, she did have near full extension against gravity. Range of motion was 5 to 115 degrees. And overall, she seemed to be doing well at that time. These are her X-rays at that time. And she didn't have any further follow-up with us, but I saw in some of the outside notes, she'd seen an outside orthopedic doctor just 2 months ago, and she still had a chronic infection, but she was able to walk and she felt that it was tolerable. So she's on chronic suppression antibiotics, doesn't want any further surgery, and plan is made just for continuing observation. These are her last X-rays.
I don't think there were any delusions of parasites, but I thought she brought bed bugs to the hospital. I'm pretty sure.
Well, you make me feel like I take care of a very healthy group.
See the ones we don't show you.
That'll conclude our LeCocq session for this year. Thanks to everyone for coming out, and huge thank you to Dr. Nelson. Let's give another round of applause.
Even if the components are.
Thanks for cleaning all that space.